அசோக் கால் ஓகேவா? எனக்கு கேக்குது. இது ரொம்ப சவுண்டா இருக்கா? ஆ, இது லேப்டாப் இதான் யூஸ் பண்றேன். ஓகே, ரெண்டு பேர் சேர்ந்துருக்காங்க. ஸோ who is joining us? Thank you for joining. We've asked everyone to log in well before the start 6:30 so that any network issues can be corrected. இதோ ஃபோன் பண்ணுறேன், ஒரு செகண்ட்.
It's 6 o'clock. Mr. Kali, am I audible?
Yes,
Uh,
madam.
am I audible, sir?
Yes, madam. You are, madam.
I just want to share my screen and see if I'm able to share it.
Yes, you can.
Can I share it?
Yes, please.
No, I am disabled. Host has disabled my participant screen sharing. Can you please
Yes,
give me
yes,
the rights to share my screen?
yes.
Yeah, let me just try. Yeah, are you able to see my screen?
Yes, we are, madam.
Okay. I just wanted to know is the meeting will be on or it will just wind up in an hour's time? Is it something like that that it will go away in an hour's time?
In 1 hour, we'll wind up completely, madam. Within
Okay,
one.
so I cannot cross that half an hour time given to me, right?
It would be nice if we can keep it for 20 minutes and 10 minutes Q&A.
Discussion. Okay, fine. Okay. Okay, thank you.
Okay, madam. Thank you.
Kali, this is Dr. Giresh.
Yes, sir.
Just give a brief introduction and I'll introduce the speaker, first speaker, and thereafter the second one.
Fine, sir. Just the usual. Yes, sir.
Just take 1 minute and then I'll take another two or three. And then you can say start off the first speaker, Dr. Madhavan, and thereafter I'll introduce the next one. Okay?
Okay, fine, sir. I'll do the introduction as usual and then hand it over to you, sir. I'll do the introduction as usual and hand it over to you, sir.
That's it, fine.
Hello, can you hear me?
Yes, Madhavan. Yes, I can hear you.
Yeah, thank you. Thank you, sir. Thank you, sir. Good evening.
Good evening. I think we have got another 3 more minutes, I think, and we'll
Yeah,
start
sure.
immediately.
Sure, sir. Sure, sir. Share option is there, sir? Hello.
Yes, hi sir, this is Kali here.
Yeah, hello. A share option is there in Zoom? Is it?
Yes, sir, it is there. So your slides will be shared by Ashok. You,
You are not giving the control to me.
if you want the control, we can give it to you,
Yeah,
sir.
that will be better if it is possible because I can move the run the slides.
Sure, sir.
Okay.
Ashok,
Yes.
um, okay, landline number.
Good evening, sir.
Good evening.
How are you, sir?
Fine, man. Thank you. Thank you. How are you? COVID warriors. Still in Momandura, then?
ஆமா சார் அங்கதான் இருக்கேன் சார்.
Going there daily or supposed
Yes
to
sir,
go?
daily sir, no role duty.
Okay. But you attend COVID patients?
Sir, we don't have COVID in our block. We have it in the adjacent block.
Okay. Okay.
So, but unfortunately, so many patients who are admitted after being negative, they are found to be positive post-operative and stuff like that.
Okay, correct.
So we get to see the case sheets, but not the patient directly.
Okay. But I have to be extremely cautious
Just having fingers crossed and going daily. That's it, sir.
because asymptomatic carriers are a big issue. Hello. Hello.
Dr. Meenakshi, you are going to. I'm Dr.
Good evening, sir.
I'm Dr. Girish.
Yes, sir. Good evening, sir.
Good evening. In fact, you are the one who, in fact, we formulated the diet for the COVID.
Right, sir. Right, sir. For Tamil Nadu government, I was the one who created the diet COVID menu 1, 2, and 3, sir.
We are very happy to hear that.
Oh, thank you so much, sir.
Okay, right. Thank you.
I think we'll start in another 2 minutes.
Yeah, yes, sir. Thank you.
Kali, it's fine with you?
Just a few more minutes, everyone. We'll just waiting for some more people to log in.
Yeah.
I think we can start, Kali, because we have almost around 31 participants are there. Playing off period. I think we have another 3 more minutes to go for 6:30. I think some more participants are joining. So I think we just wait for another 2 minutes.
Sure, sir. Sure, sir.
Okay. I'm sure in your mobile it is around 6:28. Another 2 more minutes to be 6:30. At the sharp dot of 6:30, we will start. And easily has joined. For those of you who are participating, please forward your in the chat box. Forward your name, the mobile number, and your mail ID, especially your mail ID, so that we just send a certificate of participation to each one and every one of you. So my humble request to all of you who are participating, I think we have around 63 now. Please put your name, mail ID, and your phone number, so that we can actually send a certificate of participation of this particular CME program, which is a very, very important program. In fact, we will forward the certificate of participation to you with your name on that online. Yes. Ali, can you go ahead?
Yes. Hey, good evening, everybody. Welcome. Padma Clinic and Nursing Home heartily welcomes you all to this very critical and important webinar on diabetes and nutrition. We have been doing these webinars since the time COVID-19 pandemic set in the country. We are just doing our part to spread correct, constructive medical awareness to help all of us get through this. As requested by Sir, please everyone do share your name, credentials if you're a medical professional, and your WhatsApp number and email so that we can send you a certificate of participation. To my personal WhatsApp number, if you want to as well, which is on the chat box, 8838287268. I'll type it up again. The moderation discussion will be followed by a lively Q&A session. So please type out all your questions in the chat box for the panelists to answer. Also, I will be sharing a feedback form for this webinar. To everyone, request you to take a few minutes to fill it online and just send it to me. Okay, thank you again. Now I request Professor Dr. Girish, our Chief Medical Director, to take over.
Yes, thank you, Kali. In fact, I wholeheartedly welcome every one of you, all the participants, distinguished participants, as well as the senior speakers. I think I'm Dr. Girish. I'm physician, neurophysician, and neurosurgeon, and I'm also, in fact, the former professor of neurosurgery in the government Guildford Medical College, as well as in the Rajiv Gandhi Hospital, and also the former associate dean of Vizara Medical College. And presently, I'm in fact the clinical director and the chief of a neuro division of Padma Clinic and Nursing Home. I'm in fact very proud to coordinate a series of CME programs, awareness programs, of which I myself have been in fact organizing. And today is a very important topic on COVID-19 and diabetes, which is going to be spoken by Professor Dr. R. Madhavan, and COVID-19 and immunonutrition, which is a very, very important topic, which is going to be spoken by Dr. Meenakshi Bajaj. And in fact, I must tell you that Dr. Meenakshi Bajaj is one person who devised the diet for the COVID-19, those who are staying in quarantine in the Omandur Hospital, the multi-speciality hospital. We are in fact very proud to have her with us. First, I will introduce the first speaker, COVID-19 and diabetes by Dr. R. Madhavan. I'll introduce Professor Dr. R. Madhavan, and thereafter will be the talk by Dr. Meenakshi, who is going to advise us on what foods can we take to boost our immune system so that our system fights against the coronavirus. So first, of course, is COVID-19 and diabetes by Dr. R. Madhavan. He is a very senior diabetologist in the country, and he, in fact, the various positions after acquiring his MBBS from Chengalpet Medical College and MD from Madras Medical College. He held positions like the assistant professor of the Department of Diabetology in Madras Medical College from the year 1983 to 2006. Thereafter, the professor and HOD Department of Diabetology at the Government Stanley Medical College Hospital from 2006 to 2011. And subsequently became the professor and HOD of Dr. Ambedkar Institute of Diabetology, Government Kilpauk Medical College and Hospital from 2011 to 2014. And subsequently held the prestigious position of Director and Professor, Institute of Diabetology, Madras Medical College, and Rajiv Gandhi Government Hospital, Chennai. In fact, he is an excellent teacher and had 36 years of teaching experience in diabetology for both the undergraduates and postgraduate students. And he's a life member of the Association of Physicians of India, the Diabetes Association of India, and the Research Society for the Study of Diabetes in India, then the RSSID, that is a Tamil Nadu chapter, National Faculty for the Public Health Foundation of India, examiner for various certificate courses in diabetology, have organized several seminars and CMEs in diabetology, and has got qualitative 25 publications in peer-reviewed journals. Well, he's quite a good speaker. He has managed many patients. I have seen personally myself as a consultant diabetologist to our hospital. In fact, he has managed many complicated cases, and they did walk out of the hospital normally. He, in fact, is a very simple, humble, and down-to-earth personality with an A skill in the thorough management of diabetes. And Dr. Professor R. Madhavan is going to speak to us on COVID-19 and diabetes, and will be centering around why diabetics are more prone to COVID-19, how to control diabetes and prevent getting COVID-19. If you get COVID-19, and how to control the diabetes. This will be centered around these main principles. Well, now I request Professor Dr. R. Madhavan to address. Thank you.
Thank you very much, sir, for your nice words of introduction. Good evening, everybody. I thank Dr. Girish and his team for making this possible and honoring me by inviting me to deliver a lecture on COVID and diabetes. Thank you very much. At the outset, I would like to convey that I understand there are quite a few non-medical personnel. The talk I am going to deliver is mainly for healthcare professionals, but I'll be very happy to answer any questions those non-medical people have at the end. To the extent possible, I will clear their doubts. So you know that before understanding why the diabetes is very important during the pandemic of COVID-19, we have to understand certain basic things about diabetes. So most of the data or information I give is about type 2 diabetes, because that is the maximum number of diabetes in the world. Fortunately, type 1 diabetes is less than 5%. It is 95% is type 2 diabetes. So whatever I tell you now is about type 2 diabetes mainly. So you know that we call type 2 diabetes an epidemic. It has been there spreading like a wildfire all over the world. In fact, we believe that there are around 370 million type 2 diabetics world over. And it is believed that by another 10 to 15 years, it's likely to double. And as far as India is concerned, India has almost 72 million type 2 diabetics at present. And by 2030, we believe that again, this is going to double. And there are certain peculiar features about diabetes, because this is very important to understand the basic pathophysiology of diabetes, to understand why COVID is important in association with type 2 diabetes. So the disease process, type 2 diabetes starts almost a decade before you make a diagnosis of diabetes. So by the time you make a diagnosis of diabetes, the patient already had 10 years of diabetes, and injury would have occurred to the endothelium. In fact, we say that by the time the patient becomes clinically diabetic, he already has endothelial injury. You can have diabetic nephropathy, you can have diabetic micropathy, and most important, you can have macrovascular disease, cardiovascular disease. One complication of diabetes, which is very important during the pandemic. Apart from this, the Indian type 2 diabetic patients have certain peculiar features. We call that the Indian phenotype. We are not obese like the Caucasians. Obesity is a big problem in the developing countries, but in India, so far it is not a big deal. But our patients are phenotypically obese. That means they are upper abdominal obesity. So they may have ideal body weight, but their upper abdomen is very obese. They have a lot of fat in the upper abdomen. That is one of the reasons why they have more insulin resistance. And insulin secretion is very defective in Indian type 2 diabetic patient. The progression is very rapid after diagnosis. Complications occur much earlier. And morbidity and mortality, especially due to cardiovascular disease, is much more and earlier in Indian type 2 diabetic patients. So these things have to be kept in mind while dealing with a type 2 diabetic patient who develops type 2 diabetes. Can I have the next slide, please? So this will be the flow of my talk today. I'm sorry, there is some disturbance. Why there is some disturbance? Yeah. COVID-19, a pandemic overview. Then I will talk about diabetes and COVID-19 connection, management of diabetes and types of COVID-19. What are the precautions type 2 diabetic patients have to take during the pandemic? And of course, if there are any questions and answers, I will answer it at the end of the session. Next slide, please. Can I have the next slide? Yeah, of course, as I told you, unfortunately, India is has the dubious distinction of being called the diabetic capital of the world. We feel according to the World Health Organization estimates, if you take the population above 30 years, almost 1 in 11 have type 2 diabetes. And of course, India has the largest share, 16.6% of the total world type 2 diabetic patients after China. China has more numbers. We are likely to overtake China very shortly. And of course, we know that in the ongoing COVID-19 pandemic, patients with diabetes have 50% higher mortality than those without. And in India, 73%. I think, in fact, the reason this is a little older data, according to the recent data, almost 85% of the patients who have morbidity and mortality due to COVID pandemic have type 2 diabetes and other comorbid conditions. And if the type 2 diabetic patient has other comorbidities like hypertension or cardiovascular disease or chronic obstructive airway disease, COPD, then the mortality is still higher. And more than 75% of the diabetic patients are lost to care in India. Unfortunately, they follow up the complaints with reference to diet, exercise, drug medication, and monitoring is very poor. So we literally lose these patients for follow-up. And again, that is one important reason why many of the type 2 diabetic patients who contract the infection ultimately succumb to the infection. Next slide, please. So pandemics are not new to the mankind. They have been there even before the Christian era, the prehistoric era. So there are a number of pandemics. For instance, the plague of Athens in 430 BC, almost 1 lakh people died. The Antonian plague, 3.5 to 7 million people died. That occurred in 165 to 180. So similarly, Japanese smallpox, plague of Justinian, so many things occurred. But if you take the post-Christian era, the historic period, of course, we had number of pandemics. Of course, the most important one about which we have been discussing a lot, we see a lot of information in the literature and media, is the Spanish flu of 1918 and 1919, and exactly 100 years ago, which killed all over 50 million people. So, in fact, compared to the present pandemic, it was much more bigger and more people were affected. And of course, India was very much affected by the Spanish flu. Many thousands of people died in India. Of course, we had the HIV, which is ongoing. Again, several million people have died. Ebola virus. And of course, now we have this COVID-19 pandemic. Next slide, please. So, some basic information about the coronavirus, how it affects, what are the symptomatology. So the incubation period, normally they say it is about 3 days, but it can go up to 5 days. Of course, the symptomatology includes fever, usually very mild fever. It is not a high fever. Cough can be there, especially dry cough. Fatigue, they say it's very important. Much before you get cough and cold, you can have severe fatigue. Anorexia, loss of appetite, and some people have vomiting and diarrhea also. Myalgia, severe body pain and diarrhea, as I said. Some of the people complain of diarrhea. So in the absence of any other provocations, if you have diarrhea in these days with mild fever and dry cough, then you have to be very careful, if necessary, check for COVID-19. Of course, critical illness can be very highly symptomatic. Of course, dyspnea is one of the most important clinical symptoms one has to be aware, especially elderly people. They call it the happy hypoxia.
Dr. Madhavan, please unmute yourself. Dr. Madhavan?
Yeah, now I unmuted.
Thank you.
Yeah. The happy hypoxia is one thing has to be, people have to keep in mind. So check their oxygen content with a pulse oximeter, especially vulnerable people. Diabetic patients is very essential. Everybody should buy a oximeter and check if it is below 94. They have to be very careful. Once the incubation period is over, the median days to onset after development of the critical symptoms can be anything from 2 weeks to sometimes even 3 weeks. Some people, especially diabetic patients, take longer to recover from the symptoms, and they have to be treated continuously, monitored and treated for almost 3 weeks, sometimes 4 weeks. Some of the patients have been remaining in hospital for almost 1 month, type 2 diabetic patients, because of the immunological redundancy in these patients. They are immunologically compromised, so they cannot recover immediately. They may require longer hospitalization. Next slide, please. Next slide. Can I have the next slide? Yeah, so these are all the typical symptoms. Fever, mild fever in 87% of the patients. Dry cough is one of the most important. This is not a productive cough of the other flu, like common cold. Here it's a dry cough. Fatigue again can occur. Sputum production is less, 33%. Shortness of breath is there, almost 20% can have this. And myalgia and arthralgia. Headache, again they say intractable headache, very severe headache. In the absence of any other cause, again can be a symptom. Chills, 11.4%, nausea and vomiting, nasal congestion, diarrhea, hemoptysis, conjunctival congestion. They say the virus can enter through the conjunctiva, so conjunctival congestion can be there. And of course, recently they have added loss of loss of smell. That is another very important. In fact, the government of Tamil Nadu, government of India has now included loss of smell as one of the earlier preclinical symptoms of COVID infection. So if somebody suddenly loses the loss of smell, then they have to be very careful. If necessary, they have to test for COVID. There are other symptoms like mild fever or dry cough. Next slide, please. So how do you distinguish between the common cold, flu and coronaviruses? So these are all the features. The time between catching the virus and beginning to show symptoms for cold is 1 to 3 days. Flu, it is 1 to 4 days, whereas in coronavirus, it can be anything from 2 to 14 days. So if in case you come in contact with a coronavirus, positive corona cases, you have to wait for 14 days sometimes to know you become positive in RT-PCR. So you cannot say after 3 days your RT-PCR is negative. You cannot say you don't have COVID infection. You have to sometimes, if necessary, repeat it if symptoms persist. Symptom onset is gradual in cold. It is abrupt in flu, that we know. Every one of you would have had flu at some time or other. In coronavirus is gradual. How long the symptom lasts? Again, 7 to 12 days for cold, 3 to 7 days for flu. Whereas mild cases, approximately 7 to 14 days. As I said, in severe critical cases, it can be up to even 28 days, 1 month. Fever is not very common in cold and flu, but it is again less common in, it's very common in COVID-19. Runny nose, again less common in COVID, whereas it is common in other two. Sore throat, again is less common. Mild sore, many patients complain of mild sore throat with COVID infection, but it is not as common as it is in cold. Cough, again dry cough is very common in COVID, whereas it is not very common in flu, may be common in cold. And body ache, again can occur in some patients, but when they have body ache, they say it is very excruciating pain. Sometimes occur in the body ache, joint, arthralgia can occur, but not very common. And difficulty in breathing, that is one symptom which has to be kept in mind and watched, because that is one of the main symptoms in many of the type 2 diabetic patients, especially elderly people above 60 years of age. If they have a breathlessness at rest, then they have to think of COVID-19. Next slide, please. So what is the connection between diabetes and COVID? So we know that the COVID pandemic that is ongoing now is one of the most unprecedented in the history of mankind. After 100 years, after the Spanish flu, we have this pandemic. And as I told you, though we call diabetes as an epidemic, it can also be called a pandemic. So when the two pandemics coexist, so coexistence of diabetes and COVID-19 is an unholy situation. So one can complicate the other. It can, the diabetes can make the COVID infection worse, and COVID infection can result in very poor glycemic control and complications of diabetes. So the coexistence is very dangerous. So one has to be very careful in a type 2 diabetic patient contracts COVID infection, the morbidity and mortality, the course of the disease is going to be very long. The morbidity and mortality is going to be very high. Next slide. Yeah, so the questions very often asked by the healthcare professionals and also the patients, many of the patients is, there are certain common questions they ask. Are people with diabetes more prone to COVID-19? We'll see the answer in the next PPT. Are patients with diabetes likely to get more severe form of the disease, and are the outcome is also very unfortunate? What are the mechanisms by which diabetes worsens COVID-19? Or any changes to the treatment in diabetes to be made when a person contracts COVID, even if the control is good? What special precautions should people with diabetes take to prevent the COVID infection? Now let us see one by one. Next issue. Next website, please. Yeah, so the question, are people with diabetes more prone to COVID-19 is a very difficult one. There are very contradictory information. Initially, they said that patients with diabetes are more prone for contracting the infection. They said it is as equal to the patient without diabetes. So there is no increased propensity to contract COVID infection in type 2 diabetic patients. But what has been said is that if the control is not good, there is uncontrolled hyperglycemia, then the chances of infection are more. So it is very important that the glycemia is kept under very good control to avoid contracting the infection. But again, there are some later day data. Now that the pandemic is only about 7 or 8 months old, but the recent data, again, some data shows that type 2 diabetic patients are more prone for contracting infection. So this question is not yet fully settled, but there are views about both ways. People with diabetes generally are more prone for lower respiratory tract infection. That is very well known, because even ordinary flu can become a pneumonia in type 2 diabetic patients because they are immunologically compromised. Diabetes is an immunocompromised state. So an ordinary infection can become a serious infection. But as of now, as I said, there is no evidence to suggest that people with diabetes are more prone to contract the infection. The complication can occur, the serious course of disease, morbidity and mortality, but contracting the infection is not more compared to a non-diabetic person. But again, the American Diabetic Association and the RSSDA, Indian RSSDA body suggests that people with diabetes are not more prone to COVID-19 infection. But again, as I said, the World Health Organization doesn't agree with this. They differ. They say that type 2 diabetic patients are more prone to contract the infection. Next slide, please. So, what is the reason for increased incidence and severity of COVID-19 in type 2 diabetic patients? One, the infection is increased because, as I said, type 2 diabetic patients are innately immunocompromised. Their immunological mechanism is poor because of several reasons. For instance, their phagocytosis, which is one of the most important immunological mechanisms, is defective. The phagocytes attacking the foreign body is not as good in a diabetic as it is in a non-diabetic. Neutrophil chemotaxis, which again is very important for attacking the virus or bacteria, is not good in type 2 diabetic patient. Cell-mediated immunity, you would have heard a lot about T cell in COVID infection. They say the T cell response is not good, then the complications are more. If the T cell response is very good, then the course of the disease is contained. Whereas in type 2 diabetic patient, the T cell mediated immunity again is very poor. And of course, most of the type 2 diabetic patients, especially they are old and have been having diabetes for a long time, they are very often, they have cardiovascular disease. And we know that comorbidities like atherosclerotic heart disease, hypertension can aggravate the complications of COVID infection. Next slide, please. So again, the next question is, once they contract the infection, are they more prone for morbidity and mortality? The answer is very, very big yes. Yes, they are more prone for complications. As I said, especially when they have poor metabolic control. And another factor which is being increasingly recognized is the concept called glycemic variability. It is not only poor control, as indicated by A1C of 8 or 9, but also the fluctuations in blood sugar. Well, glycemic variability we define by saying that it is a interday and intraday variations in blood sugar. You do the blood sugar in the morning, fasting is 110, postprandial is 160, you are happy. A1C is 7. So you are very happy that the control is good. You check the blood sugar in the evening, post meal, it is 450. or check the blood sugar after lunch, it is 350. So that is called glycemic variability. So the more than the control glycemia, it is the variations in blood sugar which occurs every day, morning, evening, night, that is more responsible for the complications of diabetes and COVID infection. So every effort should be made to avoid excursions in blood sugar, wide fluctuations in blood sugar, and of course comorbid conditions, especially heart disease and cardiovascular disease, increase the cardiovascular the morbidity and mortality. So patients with diabetes have an increased risk of severe complications, including adult respiratory distress syndrome. One of the most important reasons for hypoxia in COVID infection is adult respiratory distress syndrome. So this is more in type 2 diabetic patients. Multi-organ failure. Again, if you read the literature, many of the patients who die due to COVID infection, type 2 diabetic patients, die because of multi-organ failure. Originally, it was thought that COVID infection is merely a pneumonia. Now we know that it affects virtually every organ. It can affect the brain, it can affect the heart, it can affect the liver, kidney, even skin manifestations have been expressed in COVID infection. So virtually every organ in the body can be affected. So many of these patients, when they develop acute kidney injury or coronary atherosclerotic heart disease, acute myocardial infarction, heart failure, the mortality increases. And diabetes was identified as a major contributor to disease severity and morbidity and mortality in the previous pandemic, the Middle East respiratory syndrome, MERS-CoV. Fortunately, this was not very prevalent in India, but it affected some of the Middle East countries, and there they found that this is also a coronavirus. It caused more morbidity and mortality in those patients with diabetes and comorbidities. Next slide, please. So, what are the one thing we have to keep in mind, especially healthcare professionals and also the patients, is that, as I told you, diabetic patients are immunocompromised. So the initial symptoms may not be very prominent. So people with diabetes potentially may have milder early symptoms of COVID-19. So which makes subsequent rapid deterioration much more. So they come very late. Again, you would have seen in the media that most of the patients who die, diabetic patients, due to COVID, they are coming to the hospital very late. They come to the healthcare professional very late. Treatment is started very late. By the time they come to you, they already have pneumonia. They already have involvement of multiple organs. So mortality is very high. So symptomatology is alone not enough to diagnose COVID in type 2 diabetic patients. Even the doubt of COVID-19, you have to influence the patient to test for COVID-19. Next slide, please. So there are certain factors once the patient contracts the infection, which might give you some idea about the morbidity and mortality. Some are non-modifiable. For instance, age. Older the patient, that again is well known. Above 60 years, 70, 80, the morbidity and mortality is more. Male sex, for some unknown reason, as of now, the data says that morbidity and mortality is more in male sex than in female. There are certain modifiable factors, as I told you, classic cardiovascular risk factors. Again and again, we have to emphasize the importance of cardiovascular disease in type 2 diabetic patients. Hypertension, obesity, though it is not very common in India, there are a small percentage of patients. Obesity is again becoming an epidemic in India also, like Western population, because of our altered lifestyle. So obesity, especially the upper abdominal obesity, as I was explaining earlier, can be an important risk factor. And smoking, again, can be one of the important risk factors. And diabetes per se, hyperglycemia, dysglycemia, we call it, is one of the important reasons for increased morbidity and mortality. And if the control is poor at the time of contracting the infection, again, it is going to alter the morbidity and mortality. Next slide, please. So why, what are the mechanisms by which diabetes aggravates COVID-19 infection or increases the morbidity and mortality? We know that in type 2 diabetes, there is a low-grade inflammation already. As I told you, there are inflammatory cytokines because of the increased free fatty acid. The upper abdominal obesity results in insulin resistance. That results in more of free fatty acid, which results in an unleashing of inflammatory cytokines. So diabetes by itself fundamentally is a low-grade inflammatory disease. And of course, as I told you, it is an immunocompromised state. It is a metabolic syndrome. Diabetes is not merely hyperglycemia. There is always other associated pleomorphic conditions like hypertension, cardiovascular disease, hyperuricemia, obesity. So many factors. NASH, another important non-alcoholic steatohepatitis. All these things make it a metabolic syndrome. And all these factors can again contribute to increased morbidity and mortality. And of course, the overeating and or unbalanced diet. Meenakshi will be telling us about it later. Of course, that is associated with overweight or obesity. That is another reason why there is increased morbidity and mortality in type 2 diabetic patients. And of course, it has also been shown, you would have heard about the terminology cytokine storm in COVID. That is one of the important reasons why the hypoxia occurs, cytokine storm, unleashing of inflammatory cytokines. It has been shown that patients with diabetes have exaggeration of pro-inflammatory cytokine response. So the COVID storm is much more in type 2 diabetic patients when they contract infection. It is due to interleukin and tumor necrosis factor alpha, two of the most important inflammatory cytokines, which can result in hypoxia and organ failure. So diabetes and COVID-19 both are pro-inflammatory states, and they injure the endothelium. In diabetes, we always talk about endothelial injury that is responsible for all the complications of diabetes, micro and macrovascular, whether it's retinopathy, nephropathy, or neuropathy, whatever is the complication, both the micro and macro, endothelial injury is a fundamental phenomenon in type 2 diabetes. And again, the inflammatory response in COVID-19 can aggravate the endothelial injury. Next slide, please. So this, of course, I will not go into all the details. There are two ways how the SARS-CoV-2 coronavirus 2 can affect all the complications of diabetes. So there are risk factors, as I said, obesity, cardiovascular disease, diabetes, smoking, drugs. There are certain drugs the patient may be taking for comorbid condition that can aggravate the COVID condition. And vitamin D deficiency, again, from the very beginning, it has been recognized that vitamin D is very important supplement. I think Meenakshi will be telling us. So that is deficiency in vitamin D. And I can assure you that 80% of the Indian population have vitamin D deficiency. In spite of the fact that we have 9 months of sunshine, I don't know why it is, we are not able to say, probably a genetic phenomenon. 80% of our population have low vitamin D, especially type 2 diabetic patients. So even otherwise, we always advise the patient to take vitamin D supplements. So vitamin D deficiency has been shown to be one of the important causes for more morbidity and mortality. And sleep apnea, which again is component of metabolic syndrome now. Because there is no enough data to confirm this, but again, people with sleep apnea have abdominal obesity. So again, they have metabolic syndrome that again has been said to be one of the important reasons for increased morbidity and mortality. That is why you would have read about how the patients are made to lie on their abdomen when they are in the intensive care unit to reduce the breathing problem. So these things can aggravate the problem, and the virus can affect multi-organ failure, cause multi-organ failure in two ways. One is an indirect injury. As I told you, there is an unleashing of inflammatory cytokines that can result in injury, hypoxemia. The COVID storm in the lung can result in hypoxemia that can cause death, or it can cause a direct injury. Again, to the lung, we know that ACE2 expression is more in the lung alveoli. So ACE2 receptors are most important for attaching of the COVID virus to the cell, and then the internalization of the virus. So directly, the COVID virus can get attached to the ACE2 receptors on the alveoli and cause enter the alveoli and destroy the alveoli. That can also result in hypoxia. And now it has been clearly shown that COVID virus can directly attack the heart. That can result in myocardium. The myocardium can be affected. That can result in heart failure, arrhythmias, acute coronary syndromes. So these are the ways by which the COVID can affect result in multi-organ failure. And then originally they thought that it is a disease of lungs and pneumonia only. Now we know that it is a disease of multiple clotting in all the organs. In fact, every organ in the body, from head to foot, there can be microclogging due to microclot formation. That is why now they have included anticoagulants as a routine in the treatment of COVID-19 infection. So it is a microclotting. In fact, they say this clotting can affect even after the patient recovers from COVID infection. And again, we have to understand that type 2 diabetes is a hypercoagulable state, even normally, because the platelets are hyperaggregable, the clotting factors are deficient in type 2 diabetes, the viscosity of the blood is more. We call this hemorheological changes in diabetes. So already the diabetic patient has hypercoagulable state, and the COVID infection is going to aggravate this hypercoagulable state, resulting in microclots in various organs that can again complicate the disease and result in morbidities. Next slide, please. So again, the link between hyperglycemia and poor hospital outcome when once the patient is admitted, especially those patients who are admitted in the ICU, requiring a large amount of oxygen flow or ventilatory support. What happens is a metabolic stress. The infection is a metabolic stress. So already the patient has got diabetes, he has metabolic stress, metabolic syndrome. So when he has another added COVID infection, the stress hormones and the peptides, which are harmful, are secreted in large amounts. That increases the glucose and decreases the insulin. So it's a double whammy. Insulin secretion is reduced, the glucose goes up. So the combination of this results in dysglycemia. Once the insulin resistance increases, insulin secretion decreases, there is more FFA. And as I told you, FFA can result in unleashing of inflammatory cytokines, and many of these patients develop ketones. In fact, I understand from my colleagues in Omandura Medical Hospital, other government hospitals, that many of the type 2 diabetic patients who otherwise have been well controlled prior to contracting the infection, even with the combination of oral agent, are admitted with diabetic ketoacidosis, showing that there is total insulinopenia in these patients, and of course, increased lactate, resulting in lactic acidosis. And of course, at the other end of the spectrum, you have immune dysfunction, which results in infection dissemination. And of course, diabetes by itself again has oxygen, superoxide radicals. There are more of superoxide radicals, which is supposed to be responsible for complications of diabetes. That increases whenever there is a metabolic stress. That results in increased transcription factors, which are again inflammatory, and of course they again go to secondary mediators of inflammation. And of course the plasminogen activator activity, which is very important to avoid clotting inside the blood vessels, is also decreased, resulting in more clots. So the spectrum of events which I described now results in cellular injury. Apoptosis. Apoptosis is death of the cell. All the cells in the organ die. So the repair process is also compromised. Inflammation increases. Tissue damage occurs. Altered tissue and wound repair. Whenever the cell dies, there is a natural process by which it repairs itself. But here it is compromised, so there is no repairing of the cells. Then acidosis occurs. As I told you, diabetic ketoacidosis is very common. And again, the clotting and the hypercoagulable state can result in infarction and ischemia. So they say even after the patient recovers, there can be myocardial infarction and increased anginal attacks in these patients. And whenever they have this complication, naturally the hospital stay. That's why I said type 2 diabetic patients have been treated for longer when they contract COVID infection, and it can also result in death. Next slide, please. So putting it in a nutshell, the impact of hyperglycemia results in the pulmonary endothelial cell, there is a massive cytokine and addition molecule release, uncontrolled extravasation of leukocytes. Once there is inflammation in the alveoli, leukocytes are extravasated from the blood vessels. That results in severe respiratory failure. So the ICU mortality increases. Again, as I said, glycemic variability also contributes to mortality. And of course, the sequelae of COVID infection are amplified. So this is very, very important that good glycemic control. All type 2 diabetic patients should control the blood sugar level within narrow range. Try to achieve A1C of 6.5 to 7, a fasting of say below 120 and postprandial of 140 to 160 should be maintained throughout the day, so that even when they contract infection, the consequences are somewhat modified. Next slide, please. So, a word about glycemic variability. I have already told you what is glycemic variability. It is the interday and intraday variations in blood sugar. So, acute hyperglycemia during especially in the intensive care unit, whether the patient had been diabetic previously or not. So, after admission, he develops blood sugar and there are extreme variation. It is going to increase the inflammation, and that can result in poor outcome. Again, hypoglycemia also should be avoided, this has been well recognized now in ICU patient admitted for for COVID infection. So hypoglycemia again can result in glycemic variability, because whenever there is hypoglycemia, there is a rebound hyperglycemia that results in wide fluctuations in blood sugar. That again is going to potentiate a host innate immune reactions that can result in poor outcome. And as I told you, rebound hyperglycemia after hypoglycemia per se can again affect the outcomes in these patients with COVID infection. Next slide, please. So Again, what has been recognized recently in the last 1 or 2 months is that world over there are a number of research papers which have shown that the relationship between COVID and type 2 diabetes is a two-way phenomenon. Diabetes can worsen the outcome in COVID infection, and now what has been recognized is COVID infection itself can cause new onset type 2 diabetes. So this is very, very important. Once the pandemic is over, we'll know how many of these patients who have contracted COVID infection will ultimately develop type 2 diabetes. The reason set is that the pancreatic beta cells have ACE2 receptors. So they say the virus can directly attack the pancreatic beta cells and can result in not only type 2 diabetes, but even in type 1 diabetes. In fact, they say some of the patients who are admitted with diabetic ketoacidosis for the first time may ultimately depend on insulin for treatment even after the infection is treated. So this is a two-way reaction. Diabetes can worsen the COVID outcome. COVID itself can cause hyperdysglycemia and new onset type 1 or type 2 diabetes. Next slide, please. So again, the role of ACE2 in diabetes, very, very controversial. From the time the pandemic started, we know what is ACE2, an enzyme that physiologically counters the renin-angiotensin system activation. Is a receptor to, unfortunately, is a receptor to SARS-CoV virus. The SARS-CoV virus has to get attached to the ACE2 receptor in the alveoli. Then only it is internalized and destroys the alveoli. So there was initial lot of controversy, but now it is all settled. So the controversy is over now. What we now feel is that mortality and severity of COVID is not increased due to ACE2 expression. This has been the original Chinese study after the pandemic started in Wuhan. And of course, the question which was asked earlier was if many of our type 2 diabetic patients are on ACE or ARB for treatment of hypertension. So people were terribly worried. They started asking whether we should stop these medicines. But now again, this has been settled that there is no need to start the ACE or ARB. In fact, they are good for control of hypertension because hypertension is one of the important comorbidities in type 2 diabetic patients. So you can continue ACE inhibitors or the ARBs in these patients. The ACE2 receptor is not harmful. It does not increase the cardiovascular morbidity and mortality. Next slide. And there are, as I said, originally it was thought to be only a pneumonia. Now we know that it is a multi-organ disease. Thromboembolism, deep vein thrombosis, pulmonary embolism have been explained. Of course, catheter-related thrombosis, again, have been explained in some of the patients who required central venous pressure monitoring. Of course, cardiac, it can result in cardiomyopathy, no onset. We know that type 2 diabetic patients have dilated cardiomyopathy. That's very common. One of the most common complications is in heart failure in type 2 diabetic patients. So that is very common. COVID infection can either cause cardiomyopathy, new onset, or it can worsen. Myocardial injury, direct myocardial injury, and myocarditis, again, have been because the virus directly attacks the myocardium. Arrhythmias and sudden death, cardiogenic shock, myocardial ischemia, acute copulmonale, all have been described. Endocrine, again, hyperglycemia, diabetic ketoacidosis. As I said, dermatological manifestations, especially in the feet. One of the studies from Italy, this was from Italy, one of the countries which was very much affected due to COVID pandemic. They said there were lesions in the feet. They were not able to initially explain why this occurred. Even now, the exact cause is not known. In fact, they say that can be one of the pre-symptomatic, pre-disease symptom, skin manifestations. Neurologic, originally they thought that does not attack the nervous system. Now we know that the loss of smell itself is due to involvement of the brain. So it can be headache, dizziness, encephalopathy. Guillain-Barré-like syndrome has been explained. Ageusia, myalgia, anosmia, even stroke can occur, not only during the disease, but even after they recover from it. Acute kidney injury can occur, leading on to kidney failure. Hepatic, again, elevated enzymes have been seen due to injury to the hepatocytes. And of course, gastrointestinal, as I said, they can have diarrhea, nausea, vomiting, abdominal pain, and anorexia, not only during the disease, but even for several months afterwards. Lot of reports are now coming about the post-COVID sequelae. We'll see about it later. Next slide, please. So how do you manage? The most important part, how do you manage a type 2 diabetic patient or type 1 diabetic patient contracts COVID infection and is admitted to the hospital? Next slide, please. So the most important thing, fundamental, is diabetes management is going to be very, very challenging for the patient as well as the healthcare provider, for all the reasons I have explained. The blood sugars are going to shoot up. There is going to be fluctuations in blood sugar, glycemic variability. So everything has to be taken care of. So diabetes care demands a lot of self-management on a day-to-day basis. Those patients who are asymptomatic or mild disease or in home quarantine, they have to self-manage the blood sugar, do blood sugar several times a day, and adjust the dose of oral agents or insulin, maintain the blood sugar within normal range. So that is going to be very challenging. On the other side, doctors too have a tedious task of analyzing the fluctuations in blood sugar. Whether the patient is at home or admitted in the hospital, they have to monitor the blood sugar very closely and try to change the drug regimen and see that the fluctuations are not wide. They don't go into hypoglycemia. They don't go into very severe hyperglycemia. Maintain it within, we call it the time in range. The more percentage of time the patient remains in time in range with good control, the complications are going to be less. So try to maintain the blood sugar within range for a maximum number of period in a day. Next slide, please. So what are the things which can affect the glycemic control? We know because of the shutdown, or even otherwise some of the patients are not inclined, so there can be absent or less exercise. So we should always emphasize to the patient, shutdown or no shutdown, they have to continue their exercise. They need not go out. They can do it at home. There are a number of programs for type 2 diabetic patients with the online for exercise. So they have to continue the exercise. Changes in diet occur. Many of these patients tend to overeat because they stay at home, they snack, and this snacking is not only going to increase the weight, but also worsen the glycemic control. Of course, the decreased availability of anti-hyperglycemic drug is fortunately not a problem in India. But even in a developed country like America, when the pandemic started way back in February, March, there was a mad rush for insulin, especially insulin. Many people started hoarding insulin. There was a scarcity of insulin, so that is not there, but can happen in some of the countries. Restrictions in routine visits to the physician. Naturally, the physician doesn't want the patient come to him, or the patient also is terribly afraid of visiting the clinic, especially the clinic is crowded, so that is going to be a problem. And of course, leading to uncontrolled hyperglycemia and worsening status of comorbid diseases. All these factors, which I said, can result in hyperglycemia, worsening of the hyperglycemia, and hypertension also, because of the stress, obesity, weight gain, and all that hypertension also can increase. Next slide, please. So the management involves first and foremost good glycemic control. Whether the patient is at home or admitted, whether he is on oral agent or on insulin, the physician, healthcare professional should strive to achieve good glycemic control, achieve target fasting and postprandial blood sugar values and A1C target. Of course, studies suggest that glucose concentration in the airway secretion directly proportional to the blood glucose concentration. So if your blood sugars are very high, your alveoli blood sugar is going to be high. That can worsen complications of COVID infection. So very important that appropriate glycemic control is achieved to limit complications associated with hyperglycemia. And of course, preventing complication, new onset, for instance, microangiopathy, like retinopathy and nephropathy due to acute kidney injury have been shown to be more in type 2 diabetic patients with COVID infection. So every effort should be made to prevent new onset complications of diabetes, both micro and macrovascular disease. Next slide. So how do you monitor the glucose? That is very, very important. Next slide. So hemoglobin A1C has limited value, especially in those patients who are admitted in the ICU. It might give some information about, it is the average of the last 3 months blood sugar. So it might give a indication whether the patient was under control previously or not, but may not be useful for the today's treatment. Self-monitoring of blood glucose is very, very important. Those patients who are at home should be taught to do 7-point blood sugars twice in the morning, pre-meal and post-meal, afternoon, night, plus if possible, 1 at 3 a.m. to look for any early morning hypoglycemia that can result in rebound fasting hyperglycemia, but that may not be mandatory. But normally we advise a patient to do 7-point blood sugar. Every patient should be taught to do this. Fructosamine is not generally used in normal patient, but in pregnancy that may be useful because it gives the glycemic control over a shorter period. A1C is 3 months, this is 2 to 3 weeks. Of course, the latest is CGMS, continuous glucose monitoring. So that measures the interstitial fluid glucose every 5 minutes and gives a collated value. You can get a graph at the end of 7 days or 14 days. You can get a graph, or even daily basis, you can get what are the fluctuations in blood sugar. And as I told you, you can assess the glycemic variability by doing a continuous glucose monitoring system. These are all very widely available now, very cheap, very easy to attach to the patient. Patient can go about his normal functioning, anything he can do, cycling, walking, running, swimming, with the attached component of the CGMS. At the end of 7 days, we can always assess the collated value, look for the highs and lows in blood sugar, and accordingly adjust the dose of insulin or oral agents. Next slide, please. Of course, as I told you, A1C is alone is not enough, because A1C doesn't give information about the intraday fluctuations. As I told you, every day the fluctuates at different times of the day. A1C can be very normal, still the patient can have wide fluctuations in blood sugar, and this is going to increase the cardiovascular morbidity and mortality in COVID patients. So that has to be very often, if possible, the patient should be put on continuous glucose monitoring system, and the fluctuations have to be monitored. Next slide. And of course, technology today is very advanced. The use of diabetes technology can benefit the healthcare, and not only the healthcare professional, but also the patient. Continuous glucose monitoring system and flash. There is another thing called flash glucose monitoring. They are all very prevalent, very widely available in India and in any part of the country. Can be used for both type 1 and type 2 basic therapeutic benefit. And of course, the patient he need not even come to the hospital. He can communicate with the doctor, healthcare professional by cloud-based software. The technology is so advanced. All the doctor has to do is access the details of the patient's glycemic excursions from the comfort of his clinic. The patient will be in the comfort of his residence or even in the intensive care unit. I understand that even in the government setup, the diabetologists do not visit the patient in the COVID ward because of fear of contracting the infection. So they are given the data, then they advise the insulin for these patients. So such advances in technology can go a long way in reducing the patient-doctor personal interaction, reduce the chances of the personal healthcare professional contracting the infection. Next slide, please. Then comes naturally the question about the drugs. So the question is, very often in those patients who are having mild disease or asymptomatic or quarantined at home, is it possible to continue the oral anti-diabetic drug? Because that is a question many of the patients are going to ask us. Is it necessary that I should immediately switch over to insulin if I have only mild disease or asymptomatic? I am not getting admitted, I am at home quarantine. So there is no direct evidence as to the effects of various categories of anti-diabetic drugs. Again, this lot of controversy since the onset of pandemic about each anti-diabetic drug in COVID infection. We'll see one by one. Next slide, please. So if the patient has mild disease, asymptomatic, there is no need for hospital admission. There is absolutely no need to switch over to insulin. The patient can be continued whatever oral agent he has been taking, but ensure that the treatment is modified to achieve good glycemic control. On the other hand, if the patient is on a combination of 2 or 3 drugs already and the control is not good, even those patients who are mild or asymptomatic at home, it is better to start them on insulin because we don't want to deteriorate. As I said, sometimes the patient early symptoms may not be very prominent, but suddenly would have again read in the literature how patients who had very mild symptoms, suddenly they deteriorate. Of course, you would have read about in the papers how a famous singer was all right. They said he is almost normal after admission for 3-4 days. Suddenly, since last 2 days, he is deteriorated. He is a diabetic. So that kind of deterioration can occur in diabetic patients. So one has to be very, very careful about switching over to insulin if necessary, even in those patients who have mild disease or asymptomatic, to achieve good glycemic control. Next slide, please. So let us see briefly about some of the oral agents that we very commonly use in type 2 diabetic patients. Metformin. There was very big controversy at the initial stage that metformin should be withdrawn because metformin has a potential to produce lactic acidosis whenever there is hypoxemia. And we know that in COVID infection, there is hypoxemia. So they said metformin should be immediately stopped. But as days go by, with more experience, more available data, now it is said that it's not necessary to stop metformin in all patients. So as it has anti-proliferative and immunomodulatory effects, even otherwise in non-COVID patients. So decreased mortality in lower respiratory tract infection, again known, very well known, but of course there is a risk of lactic acidosis. So those patients who are admitted in the intensive care, who require large flow of oxygen or ventilatory support, naturally metformin cannot be given. thiazolidinediones again have been shown to increase the ACE2 expression on the alveoli, all the organs. So initially they thought again thiazolidinedione should not be given, but again the decision today is that if the patient is under good control, is on a very low dose, 7.5 milligram pioglitazone, and there is no chances of deterioration in hypoxemia, then there is no need to stop. But again, you have to understand that thiazolidinedione has got weight gain and water and sodium retention. That can be detrimental, especially when acute kidney injury occurs in COVID infection. GLP-1 receptor agonists, which are injectable, again they increase the ACE2 expression in the lungs. So there are some doubts whether they can be used. And another important problem is 30% of the patients who are GLP-1 have anorexia, nausea, and vomiting. Already, COVID infection itself can cause anorexia, nausea, and vomiting. So GLP-1 analogs should not be started for the first time in patients with COVID. But if they are already on COVID, if they have any of the side effects, it should be withdrawn. Next slide. So SGLT2 inhibitors straight away contraindicated. You have to withdraw if the patient. You should not start SGLT2 inhibitors for the first time if there is COVID infection. But if the patient is already on SGLT2 inhibitors, it should definitely be stopped because it can cause, not only it can upgrade the renal ACE2, which can lead to acute renal injury, but risk of dehydration and euglycemic. There is a condition called euglycemic ketoacidosis. SGLT2 inhibitors can cause it. The blood sugar will be around very normal, 250, 200, but the patient will be in ketoacidosis. So that condition is known in SGLT2 inhibitors. So already we know that COVID can result in diabetic ketoacidosis. That should be withdrawn, and better always to discontinue. Sulfonylureas, especially modern sulfonylureas like glimepiride and glycoside, they can be continued. But again, one has to be cautious about hypoglycemia in COVID patients, because if their food intake is very poor, then they can go into hypoglycemia. Of course, the last but not the least, hydroxychloroquine, which has been in discussion since the pandemic started. Many of you might be aware that hydroxychloroquine is one of the third-line anti-diabetic drug, oral anti-diabetic drug. It has been it's available in India also. One of the pharma companies is promoting hydroxychloroquine. It is given as an anti-diabetic drug. It was said to be very good for COVID infection. But again, big controversy arose after the Indian government and the Indian healthcare professionals started giving hydroxychloroquine to those patients who had mild symptoms. Of course, it is totally contraindicated in patients who are admitted in intensive care, because hydroxychloroquine can cause cardiac arrhythmia. It can increase the it can cause QT prolongation. And we know that type 2 diabetic patients already have QT prolongation inherently. So QT prolongation aggravation can result in arrhythmias and sudden death. So World Health Organization has now withdrawn the recommendation for giving hydroxychloroquine in COVID infection. But the Tamil Nadu government and the Indian government recommends that healthcare professionals who are involved in treatment of COVID patients can be given as a prophylactic hydroxychloroquine. But those patients who have cardiac disease should not be given hydroxychloroquine. It is very dangerous. It can result in cardiac arrhythmias and death. Next slide, please. So if the patient is as severe infection, he needs hospitalization, then the scenario is entirely different. So patients with severe COVID-19 infection can experience deterioration in their glycemic control, as I told you, because of the metabolic stress, and some, especially those with type 1 diabetes or even type 2 diabetics, can be admitted with diabetic ketoacidosis. So the question is, there is no question about that the OHA, if they are on oral agent, they should be withdrawn and they should be put on multiple doses of insulin. And the insulin, again, pre-mixed insulin should not be used in this patient. It should be a basal bolus infusion. By that we mean every meal, if the patient is on oral diet, should be covered with a short-acting insulin, and if necessary, a basal insulin, long-acting insulin, should be given in the morning and night or night alone to control the fasting hyperglycemia. If the patient is not on oral diet, then intravenous glucose infusion should be started, and very frequent monitoring of blood sugar, if necessary with CGMS, continuous glucose monitoring. The dose has to be, insulin infusion pump should be used, insulin should be given, and hourly monitoring of blood sugar and adjustment of the insulin dose should be done. Next slide, please. So this is how you evaluate. So if when you see a patient with COVID, again, if he has more than one risk factor, hypertension, diabetes, obesity, and smoking, So consider what are the contraindications. If he is on multiple or single oral agent, consider what are the drugs to be given or not to be given. We already discussed how the drug can be chosen. Look for glucose variability. Consider the glycemic effects of drugs like hydroxychloroquine, because there is a tendency to give hydroxychloroquine to patients who are not admitted. Steroids should be avoided, because in hospitalized patients now, steroids are one of the stable treatment method. Continuation of ACE ARB should be done, and appropriate anticoagulation. Now it has been added in the protocol for treatment of COVID infection. Of course, lung disease, coronary atherosclerotic heart disease, myocardial infarction, heart failure, all these things have to be looked. You have to evaluate for these things. If the patient has to be admitted in the hospital, then high precision CRP, elevated creatinine should be looked at, EGFR should be calculated, A1C should be tried to maintain below 7, hyperglycemia, elevated high sensitivity troponin, high BNP and NT-proBNP, elevated D-dimer, all these things for cardiovascular disease. And of course, there is absolutely no doubt that you have to stop oral agents and switch over to multiple dose of insulin or intravenous glucose with continuous glucose monitoring. Next slide, please. So intravenous administration with a perfusion device, the target should be any random blood sugar at any time of the day. This is from NICE guidelines, National Institute of Clinical Excellence. It says the random blood sugar at any time should be 140 and 180. In those patients who are younger and there is no fear of hypoglycemia, you can even try to achieve 140 to 160. Of course, with low variability. You should not push the patient into hypoglycemia, because that can result in glycemic variability. All the other diabetic medications should be stopped, and if possible, steroids should be avoided. But the steroids have been included as one of the most important components in the COVID management. But again, type 2 diabetic patients, if you give steroid, there is going to be wide fluctuations in blood sugar. So management of glycemia becomes very challenging in those patients who are on high doses of steroids. Next slide, please. Of course, BP control is very important. The target is systolic of 125 to 140 and diastolic of less than 40. Statin therapy, if the patient has dyslipidemia, as many of the type 2 diabetic patients, if the patient is already on statin, it can be continued, but you have to look for increased CPK level, because that can be a denominator of kidney injury. And of course, there is increased risk of thrombosis in type 2 diabetic patients. I told you, diabetes itself is a hypercoagulable state. So the Mount Sinai COVID-19 anticoagulation algorithm should be followed. So this is a protocol by which you give heparin or low molecular weight heparin for those patients who have COVID with type 2 diabetes. Good glycemic control with low glycemic variability. And of course, acute heart failure is now one of the complications. Again, in type 2 diabetes, now we say that heart failure is an epidemic. More than atherosclerotic heart disease, it is heart failure which is more important. So these patients can have acute heart failure because of, as I told you, myopathy, dilated cardiomyopathy. So you have to look for it. Echo is a mandatory in all type 2 diabetic patients with COVID infection. Next slide, please. So again, management of hypertension, we have already discussed. First line of drug is ACE or ARB. Of course, there were controversies regarding ACE or ARB, but now that is settled. There are some views that it can worsen the COVID infection, but the consensus today is that you should not withdraw ACE or ARB if the patient is already on ACE or ARB. Next slide, please. Of course, there are certain special situations where more important measures are necessary. Of course, one of the most important situation is where the patient is diagnosed for the first time and has to be started on insulin, especially women with gestational diabetes or non-diabetic passing through pregnancy. So it is not possible to treat these patients through telemedicine. They have to be seen very frequently by the diabetologist and the obstetrician gynecologist. So all necessary precautions to be taken. It is very important to control the blood sugar very within narrow range. Of course, there are a lot of questions about whether the COVID virus is transmitted transplacentally and what are the consequences. As I told you, COVID can attack directly the pancreatic beta cells, can result in new onset diabetes or worsen the already existing diabetic status. And of course, we also know that the fetal pancreas starts secreting insulin from the 6th week of pregnancy. So we do not know what is the consequence of if there is a transplacental transmission of the virus, what are the consequences to the fetus. And we also know that some viral infection can result in certain, especially during the organogenesis, can result in congenital anomalies in the child. But these questions need time. Only after the pandemic is over, we'll have more data. Of course, minor adjustments have to be done online, but otherwise it is better to see the patient directly. Of course, new onset type 1 diabetes, either by chance or due to COVID infection, again will require at least initially face-to-face contact with the doctor, healthcare professional. And of course, infections. Any COVID patient with diabetes can have other infections. You can have urinary tract infection, diabetic foot syndrome, which requires immediate attention, wound debridement, and daily dressing. Again, it is not possible to do it through telemedicine. The patient has to visit the doctor frequently. And again, good glycemic control is very, very important because this patient can develop diabetic ketoacidosis. Next slide, please. Of course, there are, as I said, now a lot of literature is coming out about COVID, post-COVID sequelae. Patients who have been discharged after successful treatment of COVID infection, diabetic patients, there are number of sequelae. Reinfection has been now said. They say that the antibodies persist in the blood only for 3 months. After 3 months, the antibody to COVID-19 virus disappears, so they can have reinfection. Diabetic patients can have reinfection. Acute myocardial infarction have been reported in those patients who have recovered from COVID and gone home. Acute heart failure, pneumonia, not only due to COVID, but also due to virus and bacterial pneumonia can occur. Acute renal failure, cerebrovascular accidents have been explained. Anxiety and depression is very important manifestation as a post-COVID sequelae. And one study has shown that, of course, again, we have to wait for more data. Oncologic sequence can occur in this patient because the cancers can occur. Certain cancers like lung cancer or gastrointestinal cancer can increase as a post-COVID sequelae. They say the cytokine storm, which occurs in these patients, type 2 diabetic patients with severe COVID infection, leads to tissue damage and inflammation and increased signaling factors like MAPK, leading to more cellular growth that can result in cancers. We do not know. This data is very preliminary. We have to wait for some more time before we get concrete data on these manifestations. Next slide, please. Of course, just to highlight how the post-sequelae can occur, this is a patient which now I am treating in one of the institutions I visit. This patient is a 69-year-old male. About 2 months ago, he contracted COVID infection, diabetic for 15 years. He was on oral agent plus insulin. He was admitted, treated very aggressively in the intensive care unit with high flow oxygen and antiviral antibiotic. He was discharged after 21 days. He went back home. 15 days after he went back home, he was quite normal. He developed mild fever and cough, dry cough. So they thought this reinfection. The RT-PCR was done. It was negative, but he started deteriorating. The fever persisted, cough was there. Then he had severe loss of appetite and vomiting. So he was admitted. And this is the X-ray chest. You see that the left lung is completely collapsed. He has massive pleural effusion. Right also, on the right side also, there is massive pleural effusion, but the left lung is almost collapsed, completely collapsed. Next slide, please. So this is a CT scan. Again, you see that the left lung totally gone, collapsed, and the right also there is pleural effusion. Next slide, please. So after some time, the treating the primary care physician thought of, next slide, please. Next slide. Thought of putting a intercostal tube. There were 500 ml of frank pus from the left pleural cavity. First day, this is the picture taken on the third day. On the third day, there was around 250 to 300 ml of frank pus. So this is one of the typical post-infection sequelae to COVID. So what I am trying to impress is that the healthcare physician has to be very, very careful after discharging the patient. Type 2 diabetic patients have to be followed for long periods of time, if necessary 3 to 4 months. And any symptoms, new onset symptoms, they have to be thoroughly investigated and look for post-infection sequelae. Next slide, please. So what are the precautions you take? The diabetic patient, what will you advise? Next slide, please. Of course, apart from the routine for anybody, non-diabetic or diabetic, hand hygiene, respiratory hygiene, social distancing, avoiding non-essential travel, there are certain special things for diabetic patients. Next slide, please. So good glycemic control, we have already extensively discussed about it. Frequent monitoring, if necessary, home monitoring or continuous glucose monitoring. Of course, you have to stabilize the cardiac lesions if they are present. If they have ischemic heart disease, they have to consult a cardiologist, take medicines appropriately, aspirin or clopidogrel, antiplatelet agents have to be continued. Proper nutrition is very, very important. We know that nutrition plays a major role in type 2 diabetes. Of course, Dr. Meenakshi will be telling us about it. Regular exercise, again, you have to emphasize and re-emphasize the importance of exercise. And if necessary, type 2 diabetic patients, the moment they develop even suspicious symptoms within the home, they have to self-quarantine to avoid infection spreading to the others. So this is very important. There are one extreme view that diabetic patients should be normally, even without any symptom, should self-quarantine them at home. That is always safer so that they do not contract the infection from others. So influenza, pneumonia, vaccination, again, we have started emphasizing. We already know that vaccination is very important. Pneumonia and influenza vaccine for type 2 diabetic patients. Now, there is a relook about it because it may not contain the COVID infection, but it can prevent other flu infection, pneumonia, which can confuse the picture with COVID infection. So now we have started, even adult people, 60 years and above, and children, everybody should have a influenza pneumonia vaccine. The Sanofi vaccine is now available in the market, easily available. It has to be taken once a year, so it can be given to all type 2 diabetic patients. Next slide, please. Of course, the level of prevention, there are 4 levels: primary prevention, secondary prevention, quaternary prevention, and coronary prevention. Of course, good glycemic control is there for everything. Of course, look for other comorbid conditions, treat them. Modify the drugs if they are on oral agents. Switch over to insulin if necessary. Thyroid should be taken care of because euthyroidism is very, very important to reduce the morbidity and mortality. And of course, the last one I would like to emphasize, because of the proliferation of information in the media, both print and electronic media, many of the type 2 diabetic patients unnecessarily worry. They panic and take all sort of measures. So prevention of misinformation by the healthcare professional in interaction with type 2 diabetic patients is very, very important. And of course, promotion of correct and authentic information. The webinars like this, as Dr. Girish has organized, definitely will go a long way in giving correct information to diabetic patients. Next slide, please. So telemedicine as the new normal. We always talk about new normal in the time of pandemic. I am sure even after the pandemic, this new normal is going to persist for some time. We know that type 2 diabetes is a chronic disease, lifelong disease. So it is not possible for the patient to visit healthcare professional in the times of pandemic. So telemedicine has come to stay. Previously, telemedicine was prohibited. In fact, Supreme Court said that telemedicine should not be practiced. But now the Department of Health and Family Welfare, Government of India, has authorized telemedicine. So telemedicine can be practiced now. You can give a prescription online. That is not illegal. It is legal now. So that should be encouraged both for the patient safety and doctor safety. Next slide. Next slide. Yeah. So it's integral part. Technology is integral part of now diabetes management in COVID pandemic. It has gone a great transition with the involvement of technology. Of course, glucometers, digital clinics are there. Of course, as I told you, the continuous glucose monitoring system with attachment, transmission of the data by the patient to the doctor, all can go a long way in achieving good control. Next slide, please. This again we have discussed. Glucose meters are very cheap now. For 2,000 rupees, you can get a very good glucose meter. You can do a 7-point blood sugar testing at home. You can give the data to the doctor so that the healthcare professional can modify your treatment. So patients can easily monitor their own blood sugar. It is not necessary because many of the patients are afraid to go to labs. They ask me whether it is safe to go to the lab. So sometimes it is not necessary. They can always monitor the glycemic status at home. Next slide, please. There is another thing called point of care testing. It is defined as clinical testing close to the site of the patient. So without personal contact, the blood sugar can be assessed by the point of care testing. Again, this can be easily transmitted to the healthcare professional. Then you can act according to the glucose values. A point of glucose testing has been found to have a positive impact in COVID infection, reducing the morbidity and mortality. Next slide. This is the CGMS. It gives a collated value, the graph. It can be either for 1 day, 2 day, 3 day, whatever days you want, 7 days, 14 days. It gives a graph of ups and downs in the blood sugar values that they give you when the patient is in hypoglycemia, when the patient is in hyperglycemia. And accordingly, you can modify the treatment. Next slide, please. So the target, you can always ask the time in range. We say that any pre-meal should be between say around 70, and this is somewhat very low, 3.9 and 3 millimoles. I don't think we should try to push it to 70 and 54. So ideal will be say around 100 for any pre-meal and 160 to 180 for post-meal. That will be the ideal at any time of the day. That can go a long way in reducing glycemic variability and reducing the cardiovascular morbidity and mortality. Next slide, please. Of course, should continue, healthcare professionals should continue to follow the routine management guidelines, encourage patients to follow lifestyle modification. That is very important. We have to go on re-emphasizing it. Counsel people with diabetes about potentially higher COVID severity in type 2 diabetes. And of course, re-emphasize public health prevention measures. All those things we have already discussed. Next slide, please. This is one of the last of the 2 slides. We need to reimagine how diabetes care is delivered to those patients with type 2 diabetes who are at increased risk of COVID infection, and together make the diagnosis, treatment, and management. So we have to defeat diabetes so that the morbidity and mortality when they contract, unfortunately, COVID infection is reduced. Next slide, please. So this is what Winston Churchill said after the Second World War. He said, those who fail to learn from history are doomed to repeat it. So we have to learn from this. The pandemic has given us a good opportunity to learn about the healthcare delivery system, not only about diabetes, about anything else. So I think we have to learn from this and use it even in the post-pandemic scenario. Next slide, please. Of course, the take-home points: people with diabetes are more prone to COVID-19 infection, though it is very controversial. When they get it, the morbidity and mortality is more. And any infection is likely to increase blood sugar level, and COVID infection especially increases the blood sugar level. So aggressive management of glycemia is of prime importance. Next slide, please. Thank you. Thank you very much.
Thank you, Professor Dr. Madhavan, for that excellent elaboration on COVID-19 and diabetes.
Thank you, sir.
Well, a lot of important points are there that COVID-19 and diabetes, one can complicate the other. Variations in glucose levels can occur. Hypo and hyper can produce complications. COVID induces diabetes, a new phenomenon. And it can also, you have to monitor and maintain the blood glucose level. Steroids in critical patients can in fact enhance the diabetes. HCQ not to be given, and the long-term sequelae that can occur. And the most important that you highlighted was the quinary prevention. That is false information being spread around and people believing that. I think there is one question Thangadure, Professor, has asked about pulmonary fibrosis as a sequelae. I think in the long run we can see. Anything would you like to highlight and thought?
As of now, we do not know, because it's an inflammatory disease. There is inflammation in the lung. It can occur, but we have to wait for the post-pandemic scenario, because fibrosis takes time to occur.
Well, I think that's the answer for that, and the rest of the things, of course, we can discuss towards the end of the next lecture. And as you all know, we don't get frightened that 80 to 85% of these become normal, and only 10% will have breathing difficulty, and less than 2% will be critical, of which uncontrolled diabetes will come into that as a morbidity. And diabetes, one arm or one pillar is medicine, the other is food. So that is in fact again a very important aspect. And here we have Dr. Meenakshi Bajaj, and she's a registered dietitian and nutritionist with 27 years of experience, clinical and therapeutic nutrition, certified bariatric and critical care nutritionist, certified diabetic educator, and nutrigenomics consultant. Is a state rank holder and the best outgoing student, National Executive Committee member of the Indian Dietetic Association and the Association of Diabetes Educators in India, Executive Committee member of the Nutrition Society of India Chennai chapter, the former president of Indian Dietetic Association Chennai chapter, resource person for several national and international conferences in the field of nutrition, diabetes, renal and enteral and parenteral nutrition, organized several national and international nutrition education programs, author of the Diet Metrics and Book of Food Exchanges 2019, and contributed several nutrition and health related articles in the national print and media. Received the Best Nutritionist 2019 award from the Fit Up Test 2019, recipient of the Sadhana Award 2020 for contributions in the field of clinical and therapeutic nutrition, medical nutrition therapist for the former His Excellency of Tamil Nadu, and also the formulator for the diet that is being given in the multi-speciality hospital of Omantur in Chennai for those who are staying in quarantine for diabetes. And of course, I had made a specific request to Dr. Meenakshi Bajaj that we have today an immune system in our body which resists the disease. To strengthen the immune system, what are the foods that can boost the immune system to prevent the corona infection, and in what quantity it has got to be taken and how often? Well, this talk of Dr. Meenakshi Bajaj is going to be a very, very important talk, which I would like every one of you to listen to. Thank you. And Dr. Meenakshi Bajaj, floor is yours.
At the outset, I am very grateful to Dr. Girish sir for giving me the opportunity to be talking to you on nutrition and COVID-19. And it's a very pleasant opportunity to be talking in front of the person where I joined Government General Hospital and entered the Department of Institute of Dietology with Professor Madhavan sir mentoring me. I think it's a great opportunity for me. Thank you so much. When we talk of nutrition and COVID, there is so much going around, and I would want to share not only my experience, some amount of evidence, and pardon me, I will be going a little basic also, because I find that in the participants, there are several nurses also, and common public also who are attending this session. So as everyone knows, this is today's morning paper, which tells us that we are still having, 16 cities in the country where the mortality is high with COVID, and Chennai, Theni, Kanchipuram, Chingalpet is still grappling with this COVID pandemic. And today's paper also had this small note saying if a person is with uncontrolled diabetes, gets infected, she is at a risk of complications or worse outcomes. So this was a paper which was published in 2020 recently, where they had mentioned very clearly that out of the 191 patients, 137 were discharged, 54 died in the hospital, and 48% of them had a comorbidity. The list which was topping on it was hypertension, followed by diabetes, coronary artery disease. But it's heartening to say that I think if we had some more research papers from India, it will tell us that the undernourished population, the population which is having a very low BMI, which is not having access to food itself, where is the question of immunonutrition? Then most importantly, a lot of bariatric surgery patients. I think we have a singer, a very well-known singer also who's presently hospitalized, who Professor Madhavan sir was mentioning that he's a diabetic also. But one needs to remember that post-bariatric patients, if they don't handle their nutritional status, they are also immunocompromised. And obviously we have a lot of list of immunocompromised patients also. Probably if a study is done in India, we may get more light on it. And this is a small information telling us that the HbA1c, if it is of poor control, is also found that the mortality rate is much higher in patients with diabetes. So every morning we look up for the newspaper, for the WhatsApp University to tell us, is there a new mask, is there a new vaccine which is available, or is there a new glove which can actually help us prevent from this COVID? But look at the line when it comes to proper diet, proper nutrition supplementation, exercise and rest. This line does not exist. But I think this COVID pandemic has taught several of us that how nutrition could be the, pleasant route or a natural route which could help us boost our immunity, not only the innate, but the adaptive immunity also to fight this COVID pandemic. So when it comes to nutritional deficiency, it's associated with impaired immune response, cell-mediated immunity, cytokine production, which sir was talking of, the cytokine storm, and associated secondary opportunistic infections like the leaky gut, which is also very important information to be kept on mind. Then the secondary antibody response and affinity. So I would want to throw some light on evolution of healthcare. In 2000 BC, one said, here, eat this root. Then they said, no, no, it's not right to eat a root. Say a prayer. They said, no, no, prayer is also superstitious. Drink this potion, which is nothing but snake oil, which was venom. And they said, no, it's time you swallowed a pill. After a while, they realized there is a lot of resistance to a lot of antibiotics by misuse of antibiotic when it is not advised to take over the counter antibiotics, when it is not prescribed, and you land up with antibiotics ineffective. And today we know that we don't have any antibiotic to help us with this COVID pandemic, and we are back to our roots. So when I say we are back to our roots, what do I mean by saying that? If you see in the market, you're having golden latte or the turmeric latte, you're having the turmeric basil bread. Basil is nothing but the tulsi leaves. You're having a lot of preparations out in the market which tell you that they are immunoboosting. Now, one needs to understand spices not only give us taste and flavor, they also help us fight disease. When, there is evidence to what I'm saying, spices have a very high ORAC value. ORAC value is nothing but the oxygen radical absorbance capacity. So as simple as the curcumin in the turmeric, the piperine in the pepper, like that, a list of specific bioactive components like the gingerol and the shogol in the ginger, and the drumstick leaves are the highest when it comes to the ORAC value. See, India is, we talk of we talk of diversity in India with unity. So here we need to add on, along with the religions, the culture, the tradition, the food, the variety of dance, music, which is present in our country. We have a rich heritage of spices, which are our own, which are found available throughout our country. And most often, if you look at the slide, you'll find that, Andhra Pradesh, Tamil Nadu, Kerala is a major producer of these spices. And if I'm to talk of the antioxidants present in these spices, one needs to remember whenever one talks of, manjatul paalla pottu kudinga, you have to add ginger, you have to add pepper also. Why do you have to add pepper to it? The reason being the piperine makes the curcumin bioavailable to the system. So they work in combination. So you are going to take only turmeric and milk, is not going to do as much as when you add on pepper to the milk you're consuming. Then I was mentioning to you about this ORAC value. If you talk of all the berries, all the cherries, the walnuts, the raisins, the pomegranate, you choose and it's got an ORAC value. But then the highest ORAC value, if you see, is present in drumstick leaves. Now, drumstick leaves or the moringa leaves are a source of magnesium, or a source of iron, calcium, insoluble fiber, which will also help in good glycemic control. It can be consumed both in the uncooked form, in the form of a green smoothie. You add it on to some fruit like an apple or an avla, or add some ginger, add some mint leaves, some coriander leaves, make it like a smoothie and have it, or have it like your typical moringa soup or the drumstick leaf soup or the murunkeera sambar. In any form, you can add the murunkeera, which will do wonders when it comes to the ORAC value. Next important thing is, whenever we talk of these spices, they have something called the acceptable daily intake. You cannot take these spices above the acceptable daily intake. Reason being, they will not do their job. What is their job? To improve our immunity or to improve the antioxidant capacity. But if they are taken in excess, they will not do their job. Same way, for example, if you take ginger, has a great ORAC value when it is consumed raw. When it comes to garlic, it has got allicin, and whenever you take garlic, you have to either finely chop it or grind it into a form paste. But this paste or this chopped garlic has to be left aside for 10 minutes. Unless and until it is left aside for 10 minutes, it is not going to release allicin, which is having a potent antioxidant capacity. Now, when it comes to tulsi leaves, you are not supposed to take more than 2 to 3 grams per day, especially when it comes to men, because it interferes with spermatogenesis. But otherwise, basil leaves can be consumed, like, I think in South India, all of us have been used to consuming tulsi leaves on a regular basis. When it comes to black cumin seeds or the karanjeeragam, remember that some of them cannot handle it, even though the acceptable daily intake is 2 grams. When I say 2 grams, it means 4 pinches a day. If you're going to cross the 2 grams, it may not do good, point number 1. Point number 2 is some people are intolerant to it. So you may land up with diarrhea or abdominal discomfort. So whenever you're choosing on such add-on adjunct therapies, To improve your immunity, remember to start slow based on tolerance to continue it. When it comes to coconut oil, it's a super immune booster because of the monolaurine and the lauric acid present in it. But when it comes to dyslipidemia or congestive cardiac failure or a type 2 DM with complications or somebody who's obese, who's at risk of COVID-19, he or she cannot take coconut oil in large quantities. I would say in children below 12 years of age to take extra virgin cold pressed coconut oil alternate days, at least 1 teaspoon a day, because of the MCTs as well as the monolaurine and lauric acid, it will do good. When it comes to tomato, there are two things to this tomato. One is it has got the lycopene, which is an immunobooster. Second is the tomato is a rich source of vitamin C. But remember, when it comes to vitamin C, if you're going to cook it, the vitamin C is oxidized. So the purpose of consuming the tomato is lost. But when you consume the tomato for the lycopene, it's a great source of antioxidant. That is why the tomato rasam, the onion tomato tukku, I think in the menu which I have prepared for the quarantine patients, we've included murungeera soup, we've included tomato soup, we've included onion tomato tukku, which can be consumed either in the morning or in the night on regular basis to build up their immunity. When it comes to fenugreek seeds, everybody knows it's a source of omega-3 fatty acids, soluble fiber. It helps in good glycemic control. But you can take about 1 teaspoon per meal prior to the meal and prefer to take it in soaked. After soaking it, some patients have the habit of soaking it and drinking only the water and discarding the fenugreek. There's no point of doing that. You have to consume it with the fenugreek. Now, when it comes to flax seeds, they are a source of omega-3 fatty acids. But remember, the European Food Safety Guidelines do tell us that you're supposed to limit the flaxseed consumption to not more than 1 teaspoon, especially when it comes to children. And remember, you're supposed to take it only in the whole form. You're supposed to munch on it. You cannot buy powdered. So many patients buy powdered flaxseed. Flaxseed is a source of omega-3 fatty acids, and anything which is a source of fat, it's going to get rancid. So you're not supposed to grind it and keep it, but in case you insist that you're not able to chew on it on regular basis, so what you can do is you can just grind a very small quantity, say 50 grams, and refrigerate it so that you can, replace this ground form of flaxseed in about 3 to 4 days or about 6 to 7 days. When it comes to walnuts, yes, when it comes to walnuts, they are a source of zinc. When it comes to cashews, they are a source of resveratrol. But just because cashews are a source of resveratrol, you cannot choose it for cardiac patients or those with dyslipidemia. And remember that they are also a source of plenty of calories. I've mentioned to you even when it comes to cinnamon. Yeah, cinnamon has a great potent to improve glycemic control. So many patients are suggested to powder cinnamon. Remember, there are two types. One is the roll type and one is the bark type. When it comes to the bark type, it is the adulterated cinnamon. I repeat again, the bark cinnamon, which is found in several biryanis or the non-vegetarian foods which one consumes, choose only the roll. The roll is the unadulterated form of cinnamon. But cinnamon also has an acceptable daily intake. You cannot cross 1 to 1.5 grams daily, and that too you have to limit it only to 3 months. You cannot take it beyond 3 months. You have to wait for another 6 months after the 3 months consumption to restart cinnamon intake. In fact, patients can sprinkle cinnamon on food or on the fruit they take, not only for glycemic control, but also for their ORAC value. When it comes to children, we usually tell children not to consume chocolates. But this is the time when they want to step up their zinc intake. They can take cocoa in the form of fruits and nuts, chocolate, occasionally remembering dental caries in mind. Now, how do you shore up your defense? Avla, one avla can give you as high as about say 10 grams of avla can give you as high as 60 milligrams of vitamin C. Your vitamin C requirement moves from as low as 40 milligrams to as high as 80 milligrams. In fact, several ICUs, COVID ICUs in premier institutes use as high as 1 gram of IV vitamin C in the COVID ICUs. But I would say, in practical routine life, you can choose 1 avla or 1 capsicum or 1 guava. 1 guava will give you more than 200 milligrams of vitamin C, which is a natural form. It can be consumed by a person suffering with diabetes, with cardiac complications, with obesity, children, elderly, adult, except for the renal compromise, where their serum potassiums are high, where there is hyperkalemia. I would suggest them not to take a whole guava, but they can probably take a piece of guava. When it comes to garlic, remember that it can even trigger a migraine. So not everybody are comfortable with raw garlic, but you can consume as high as 2 grams a day in the form of a poondu kolambu which is also part of the COVID menu, which we have mentioned for our patients. It can be taken in, ginger garlic paste, in the poond chutney. Several patients take poond chutney also in order to enhance their immunity. One important message which I want to share here is, you have star anise. I do not know if anybody has seen the star-like looking spice found in several biryani preparations. This star anise has some research to tell us that the important antioxidant called shikimic acid is an important immune modulator and has antiviral properties. But remember, you can add just a pinch or two, not more than that. In fact, we tell the children to take a teaspoon of honey, add a pinch or two of the star anise, and probably you can also, squeeze some amla juice and provide it to children. But for a person suffering with diabetes, you cannot choose on honey. Now, when it comes to sweet potato is a source of beta carotene. We also know vitamin A is an important antioxidant and immunobooster. It has got a source of, it is an important source of anthocyanin, conjugated phenolic acid, carotenoids. In fact, if you squeeze some lime over the sweet potato and consume it like a mid-morning snack or as an evening snack, even in a person with, diabetes, it will not increase the postprandial blood glucose. As I mentioned to you, you can choose on fish, but fish should be, home cooked. And you have to be very careful with where you're buying the fish, because it's a source of omega-3. But at the same time, if it is old, stale fish, you're going to add on to trouble to yourself. And an important message here is, when it comes to the kalonji seeds or the black cumin seeds, which I was talking to you of, it can be added either to the gravies or to the poriyal or to the chapati dough or to the dosa batter. But remember, not more than 4 pinches a day. If you cannot measure really the 4 pinches, it could be quarter teaspoon leveled per day. This is a slide which is telling you each of these, immunonutrients or spices which can be taken in how much quantity per day. Especially when it comes to turmeric, do not take it more than 2 grams per day. There are some studies to tell us that when excess of turmeric is taken, it actually acts on the liver also. So everything has to be limited. You cannot cross limits when it comes to anything and everything. Another important thing when it comes to garlic and all these spices, some of the patients who have, GRD, or they are having already existing some ulcers or upper GI tract inflammation, if they consume too much of these spices, it may add on to gastritis. Now, there is some research to tell us that acute respiratory tract infections are responsible for approximately 2.65 million deaths per year. And here we are talking of COVID-19. So there is enough research to tell us the important nutrients which will build up our immunity are the protein, the vitamin A, B6, B12, C, D, E, iron, zinc, selenium, magnesium, copper, icosapentaenoic acid, docosahexaenoic acid. But this whole list is exhaustive. So we pinpoint to certain important immunonutrients which can be consumed on regular basis in order to enhance our immunity, and they are found to be vitamin A, vitamin D, zinc, selenium, probiotics. These also can be taken in natural form as well as in supplement form in those who are really deficient. Now I'll come up, excuse me for going very basic in few of my slides. Reason being, we are having a combination of participants for this webinar. See, when we talk of protein, we all know that protein promotes recovery, helps in wound healing and infection and stuff like that. But remember, if you are having a already existing diabetic nephropathy, you're walked into stage 4 and stage 5, you cannot think of too much of protein, then you may be actually worsening your situation. At the same time, in fact, recently I had a patient who called me and said, "Madam, I have had several concoctions of these spices and concoctions of these juices and soups in order to build up my immunity, but my potassium has picked up to as high as 6.5. So remember, when it comes to patients who are on a polypharmacy or who are already having, a long list of prescription and they are managed by specialists, they cannot take any of these immunoboosters without the prescription of the treating consultant or the associated, the add-on dietitian who was handling that particular patient. When it comes to protein, remember that you have the 2 types of protein. One is the good quality protein, second is the moderate quality, and third is the poor quality protein. See, usually the dal, the rice, the wheat, the oats, all these pulses and cereal grains which you and me consume are a source, not a great source of protein. You know, in the sense that they are not good quality protein. When it comes to good quality protein, I mean to say high biological value protein or complete protein, where most of the amino acids, all the amino acids are present. Only when certain amino acids are limiting, then the protein becomes an incomplete protein or a poor quality protein. In fact, the idli and the dosa which you and me consume are in the ratio of 4:1, 5:1, 3:1. That becomes a complete protein because the amino acid which is deficient in the urad dal is present in rice, and the amino acid which is deficient in rice is present in the urad dal, which makes it a complete protein. So always choose on dal with the cereal at the same time in the ratio of 4:1 or 5:1 a minimum. Obviously, you understand that all the non-vegetarian sources and the milk and the dairy sources are a good quality protein. They actually do wonders when it comes to your immunity. If you're a non-vegetarian, remember to choose on egg whites on regular basis. If you're having dyslipidemia, raise in cholesterol, congestive cardiac failure, diabetic with several associated complications, then only you need to worry about restricting the egg yolk. Otherwise, I think 3 eggs per week are a great to do because of the source of, it's a combination of several nutrients present in the whole egg. When it comes to nuts, remember they are a source of zinc. But if you have seen traditionally, all of us soak the nuts, like the almonds are soaked overnight. All our grandmothers and elders have been used to giving us nuts in the soaked form. Usually when you soak a particular nut or sprout it or ferment either nuts or whole grains like the sundal variety, the zinc present in the sundal as well as in the nuts will be bioavailable to us. The reason being the phytate present in the almonds and in the whole grams will get inactivated and will make the zinc available to our system. So remember to sprout, roast, or soak the nuts or the whole grams before consuming, not only for the protein, but also for the zinc. Now, vitamin A, I've already mentioned to you, sweet potatoes, squeeze some lime over it, papaya, milk, green leafy vegetables, even the drumstick leaves, they are all a source of vitamin A, which needs to be consumed on regular basis. Now, when it comes to vitamin D, we are aware that vitamin D, when it comes to food, the sources are like cheese, egg yolk, but the quantity which is present in them is very, very small. So what is the second option? You can choose on fortified oils, fortified milk, fortified orange juices, which are fortified with vitamin D. But if you're a diabetic, definitely I would not suggest you to take a juice, even if it is fortified with vitamin D. But at the same time, you can expose about 18% of your body, especially you just expose your arms between 11 a.m. to 3 p.m. for about 15 to 20 minutes, maintaining social distancing. You will see the required vitamin D will be bioavailable to you. But if you're an elderly and immobile and you're not having access to the terrace or you cannot do social distancing and do walking for several reasons, then you'll have to think of vitamin D supplementation. Because there is enough evidence to tell us COVID virus 19 is known to cause an excess of pro-inflammatory cytokines, and vitamin D modulates this response. So this is some evidence to tell us. Now, when it comes to vitamin C, I've already mentioned to you, either is the avla. Avla is much more dense a source when compared to 5 or 7 oranges. Whether it's the avla, whether it's the capsicum, whether it's the tomato or the berries, they are a super source of vitamin C, along with the greens, specifically when I say the murunkire, which can be consumed raw, or the guava also. Now, there is some amount of evidence to tell us that vitamin C is important. I don't think I want to go into that. Zinc also I've mentioned to you. There are some research papers to tell us how valuable zinc is. But an important thing, when you take zinc supplements, remember, only 23% of the total zinc which is present in the zinc is available to your system, which is bioavailable. And as I've already mentioned to you, non-vegetarian sources, especially the oyster, lobster, poultry, it's the organ meats which are a source of zinc. So if somebody is suffering with diabetes or cardiovascular complications, I would not suggest them to take organ meats to choose on zinc. Then probably they'll have to think of, sprouted whole grams, soaked soya beans, same seeds, sunflower seeds, pumpkin seeds, almonds, cashews, cocoa for the source of zinc. But even then, if you're not able to meet, then probably you may have to think of a prophylactic small dose of zinc. Now, when it comes to vitamin E, it's always the nuts, and the healthier nuts are always the almonds or the walnuts. Even the carbohydrate count is 0 when it comes to a serving of walnuts or almonds, which is about 12 to 14 almonds a day or 6 walnuts a day.
Half an hour
When it comes to
huh?
omega-3 fatty acids, remember the Vendium which you consume, the green leafy vegetables, the walnuts, the sundal which you consume are all sources of omega-3 fatty acids. But remember that when you take adjunct therapy, especially if somebody is having gestational diabetes or pregnancy with hyperglycemia, you are not supposed to take adjunct therapies like cinnamon, fenugreek, flax seeds, and all these adjunct therapies to build up your immunity, because we do not have research papers when it comes to gestational diabetes or pregnancy with diabetes to take adjunct therapies. Yes, selenium is a super source when it comes to organ meats. Once again, it's a big no when it comes to dyslipidemia or PWDs. But yes, wheat bran, eggs, sesame seeds, chia seeds, garden cress seeds, fish are a source of selenium, which play an important role to reduce the oxidative stress. A very, very important information here is you need to keep your gut healthy. You know, when you do junk eating, unhealthy food, processed meat, processed foods, you're going to disrupt your gut microbiota. And gut is a very important immune organ for which you need to do clean eating and choose on prebiotics. What are prebiotics? Oats, raw banana, onion, garlic, barley. All these are prebiotics, which in turn help to synthesize the probiotics. Otherwise, there was a research paper, I don't remember the year of publication, but from CMC Vellore, which very clearly said that during the, in the olden days, when they used to consume the curd, which was fermented and placed overnight and added on to your meal the next day. That is, the sour fermented curd is an important source of probiotic. For those who cannot tolerate that and who do not consume prebiotics, who do not do clean eating, then they'll have to rely on probiotic supplements. But I would say you can go into natural forms of probiotic like the flax seeds also. But remember, when it comes to children, not to take more than 1 teaspoon of flax seeds. Now, polyphenols are a very important source to improve your pulmonary function. Now, in fact, recently I had a patient who was admitted in KMC, and this particular patient was, initially ventilated, then on a CPAP, then put on rice tube feeding, and then started oral feeds with intermittent oxygen therapy. And this particular patient was put on steroids. So even with any amount of, dietary management, we could not, achieve good glycemic control. That good glycemic control could have been only achieved with, adequate monitoring and insulin therapy for that particular patient. But when that particular patient was put on the ideal supplement, which is used in enteral feeding in a COVID-19 patient, is usually a semi-elemental formula, and semi-elemental formulas usually worsen the glycemic control, but that has to be handled with adequate insulin management. But once the patient is off the enteral feeds and patient starts taking orally, it's very difficult to take a semi-elemental formula. It's not very, very palatable. Then you can go on with diabetic specific formulas, which help to improve good glycemic control. So always remember, when it comes to a person with diabetes, we need to go patient specific. You cannot have the same prescription or a blanket prescription for all people with diabetes. And in fact, I think Madhavan sir's slide beautifully showed that in COVID-19, there could be a risk of diabetic ketoacidosis or ketosis. So it's very important that you do not take a ketogenic diet or an intermittent fasting or a prolonged fasting, especially in the COVID-19 situation, whether you're a diabetic or a non-diabetic in obesity, because this recent paper very clearly tells us that in obese patients, it is not wise to initiate aggressive weight loss through keto diet, intermittent or prolonged fasting, because no sudden change in diet pattern or activity will do good to the patients. In fact, a very young boy of my department, unfortunately, was found COVID positive. When he was working in the department on duty, he told me, ma'am, I had fever about 2-3 days back, and I applied some sandanam on my face, and I had some cold lime juice because I was feeling very, very hot. I think that's why I developed some cold cough fever. But after about 3 days, he told me he's got anosmia. That is, he lost sensation of taste as well as smell. And I told him this is the first very few symptoms. I think 70% of the patients who have been referred to me have been referred to me with sense of, smell being lost. That's most of these patients come to us with this complaint. And when I told him this is one of the symptoms, after about an hour, he told me, ma'am, I'm COVID positive. Can I tell you that this patient, this particular staff of mine, is a teetotaler, non-alcoholic, non-obese, non-diabetic, no other comorbidities. But the most unfortunate thing was, for the past 5 years, for several reasons, he would skip 2 meals a day and take only 1 meal a day. So which means that if you are immunocompromised only with poor nutritional status, with poor, macro and micronutrient intake itself, you are at a high risk of COVID-19. So you need to go. Remember that somebody with liver failure, with cirrhosis of liver, we cannot be telling the patient to take soups and spices, or somebody with renal failure, somebody with gastropathy cannot be suggested to take a lot of green leafy vegetables, because the patient, cannot consume too much of fiber in such a situation, with gastroparesis also. And I think the best is the plate model. Take about quarter portion of your cereal. Usually the food order pattern we tell the patient to take, if you want good glycemic control, you want to achieve good weight maintenance and lose weight through healthy diet or a balanced diet, what we suggest the patients is, first start with fiber, then take the protein, and then take the carbohydrate portion or the cereal portion. So this will in turn reduce the postprandial glycemic excursion. Not only that, it will give you satiety and also help in weight maintenance. So this is a small exchange list which we help our renal failure patients. How we can calculate when it comes to the potassium phosphorus. If somebody is compromised with renal complication, how would we plan a diet? This is the food order which I was talking to you. Portion control is very, very important. And always remember never to take a fruit along with your meal, especially when you're suffering with diabetes and you want good glycemic control. Take a fruit in between your meal, and the best fruit would be a citrus fruit, because the carb counting is also low, the glycemic index is low, the glycemic load is low. But just because the glycemic index and load is low, you cannot choose in large quantities. This is a small snapshot of the GI and the GL of the foods from the book which I have authored, which is a handbook of food exchanges, which very clearly tells us that the citrus fruits, other than the banana and the dates, the rest of the fruits come in the moderate and the low GI and GL. And never to take it in the form of a juice. We know that hypertension is a very important risk factor when it comes to COVID-19. So keep your salt as low as possible. Avoid the pickle papad, the urka, appalam, vattal, molaga pudi, uppu biscuit, uppu bread, uppu kadala, soda maavu, samyalle, padapata unapurkal. All the processed and the canned foods should be out. The salt shaker on the dining table should be out. And keep away from the molaga pudis, which you love to eat the idli and the dosas with. Keep hydrated. And remember, your hydration cannot be fruit juices when you are suffering with diabetes or with renal failure or with fluid restriction. But otherwise, hydration is important. And you can choose to take a minimum of 30 ml per kg body weight in adults, and children at least 125 ml per kg body weight. Now remember, it's difficult to measure volume. You can't be measuring volume unless you're a renal failure or a cardiac failure patient. Otherwise, the best thing is to keep the color of your urine colorless, even if you are on B vitamin supplements, to note that your hydration status is good. And avoid drinking alcohol, because it leads to gut dysbiosis, and gut dysbiosis can also be compromising your immunity. And I've already mentioned to you about the formula feeds which have to be used. But remember, we are still in a situation, we do not know how the virus is shedding. So is it okay if we just maintain our boost up our immunity with diet only pre-COVID or till the COVID pandemic settles? No. We have evidence to tell us that there could be a reinfection. As Professor Madhavan was saying, this particular patient had a lung collapse, and the attender was arguing with me and also telling me that, madam, he is COVID negative, but sometimes a viral load is not enough to tell us whether the patient is COVID positive or COVID negative, but it's done its damage, and it is possible that could be a recurrence. So it's important to maintain good health, balanced diet, whether you're COVID positive, COVID negative, whatever may be the situation. The need of the hour is to follow a balanced diet and immunonutrient rich diet, and do clean eating, and remember to be physically active. But there are so many patients we have lost with excessive physical activity with mask on. So when you're doing excessive physical activity, remember that you're not supposed to have your mask on. So these are the foods which I was talking to you of. And important message here is, no one food is recommended over another. And eating a variety of foods will help to maintain a healthy, balanced diet and help fight this viral pandemic. Eat right for COVID fight was a message given by the NIN director, Dr. Hemalata, I think, which we need to follow. For a viral disease like COVID-19, when there is no pharmacological strategy, we need to understand that few vitamins, trace elements, and several nutraceuticals and probiotics play an important role, and selective micronutrient supplementation may be beneficial, especially for the vulnerable population, such as the elderly. I would want to share one small recipe which I tell everybody in my house as well as around me, whoever is, I have access to drink this in the morning every day when they start their day. That is boil milk with 2 pinches of turmeric, 2 to 3 pods of whole pepper, not crushed very finely, a piece of ginger, and 2 to 3 leaves of basil leaves, that's the tulsi leaves, with a little bit of cardamom for flavor, a pinch of cinnamon to add to it, and have this as an immunobooster in the morning and the evenings. I wish that we are off this mask very soon and we all wear this beautiful smile, which will see miracles in life of every day in every person. Stay safe. Prayers for everybody's safety. Thank you for this patient listening.
Thank you, Dr. Meenakshi Bajaj, for that very interesting lecture and also telling us the recipe for boosting the immune system. In fact, you highlighted about the turmeric, ginger, the pepper plus turmeric should be taken. In fact, the glass of milk to boost the immune system. And about the drumstick leaves, tulsi leaves, tomato, it is better to be taken raw. And very many other aspects you had already said about the proteins, the importance of it, and various publications on that. And the most important message which you have conveyed is there should not be any dieting during this period of COVID-19 because it can alter your nutritional basis and you can develop other problems actually. That is very important, and to hydrate very well. And the proteins, in fact, can boost the immune system because the studies have shown that L-arginine amino acid can improve the T cell aspects actually, which is in fact the basis of the immune system, which will function which will monitor the function of the other cells. And you told that it is supposed to be taken in milk, that pepper plus turmeric plus ginger plus tulsi plus cardamom plus cinnamon. Meenakshi Bajaj?
Yes, sir. Yes, sir.
It has to be taken with the milk in the morning?
No, it can be taken in milk. It can be taken in any form, but this is a convenient concoction which any one of us can consume, sir.
Can I ask you,
yes,
when
sir.
you take turmeric, how many pinch of, see, 1 pinch is 0.3 grams. So 3 pinches.
Sir, when it comes, we've done some measurements and we've identified that 2 pinches is 1 gram, sir.
Oh, 2 pinches. So that
yes,
means
sir.
2 pinches of pepper, little of tomato.
No, sir, pepper has to be a whole pod, 3 to 4 whole pods of pepper. Not very finely crushed, just crushed enough so that they are broken into 4 splits. Okay. So 2 to 3 pieces of whole pepper with a small pinch, with a small, half inch of ginger, fresh, not dry powder. Along with that, a pinch of 2 of cinnamon powder, 2 to 3 tulsi leaves. If you are a non-diabetic, you can add half teaspoon of sugar. You add little bit of water, say 20 to 30 ml of water to the milk. Boil it well so that it becomes a small concoction, and take it in the morning and the evening. And remember, if you can manage to take tomato soup or murungeere soup and boiled sweet potato with squeezed lemon on it and 1 avla a day, somehow you crush it and blend it in the mixie and take it like 1 teaspoon also fresh avla, it will do wonders. And remember, if you can manage to take egg whites and almonds or walnuts, but soaked almonds or soaked walnuts, they'll do wonders for your zinc.
Okay. This short and sweet recipe, to boost the immune system, kindly mail it to us so that we'll mail all the participants actually today.
Surely, sir. I will mail the immunoboosting diet which I have prepared. Not the extensive one which we are using in the government setup, but a simple one which you can, follow in your day-to-day life.
Yes. Now, only thing I have to say that zinc and vitamin C, you have said, both in combination, we have it in Goyapada. Goa.
Sir, guava has more of vitamin C than the zinc. Zinc is present majorly in the non-vegetarian, the nuts and the sprouts.
Nuts and the sprouts. Okay. See, we have participants here from almost from Amrita Institute of Kerala to almost Dr. Thagat from Arunachal Pradesh. We had a quite array of them. Now, I'd like, what you can say, anybody would like to ask any questions, in fact, can unmute and ask a question to Professor R. Madhavan as well as to Dr. Meenakshi Bajaj. The floor is open for the next 5 minutes. Anybody can unmute yourself and please ask questions on your diet or anything if you've got any doubts.
Or if you can raise your hand in the chat box, I can unmute you, please.
There is one question by Tangaduri to Dr. Meenakshi Bajaj.
Yes,
That
sir.
is about probiotic. Which probiotic is good for COVID-19?
Sir, I would suggest prebiotic. Prebiotic is onion, garlic, barley, apple, oats, fenugreek, which if consumed on regular basis will synthesize probiotic.
Okay. So garlic, barley,
onion, barley, oats, fenugreek, apple.
fenugreek, apple. Okay, good. So that's the answer for Tangaduri. I think he has asked one question. Anybody else would like to ask?
Zinc and selenium rich fruits.
See, when it comes to selenium, wheat, the wheat you and me consume, the wheat bran, the whole egg, the sesame seeds, that is the yellow, chia seeds, garden cress seeds, and fish, and especially the organ meat like kidney. But I would say, in those patients who have problems associated with dyslipidemia and cardiac issues, I would not suggest kidney. But otherwise, in the younger population, who are without any comorbidities can consume kidney at least once or twice a week to step up their selenium intake, or the whole wheat, the whole egg, the yellow urinde, chia seeds, or the garden cress seeds. But remember, they are not supposed to be taken by pregnant women. When it comes to zinc, the wheat, the chapatis could be prepared from whole wheat or the wheat dosa, the gingerly seeds, the almonds, the whole grams, all these are sources of zinc. Apart from that are the oysters and the shellfish. But I do not know, how safe it is to pick up oysters or shellfish or lobsters or prawns to consume presently. So I would say the natural sources could be whole wheat, cocoa, sesame seeds, almonds. All these are super sources of zinc.
Yes, any other questions? Anything? Divya, Gayatri, Sabita, Dr. Ishwaran, ask Governor Ranganathan. Any doubts? Appa Swami Damodaran. Anybody would like to ask any doubts? Either Professor Madhavan, diabetologist.
No doubt, sir. Very, very well explained. Thank you very much.
Yes, Appa Swami Damodaran, please tell.
No doubt, sir. It's very well explained. Even we are using those items very.
That should be very explained.
What about peanuts?
Peanuts are also a source of zinc, ma'am. You can consume them, but they are a source of saturated mono and poly. The calories are very high, but occasionally if it is consumed in your aval upma or in the form of a verkadla chutney or in the form of a verkadla urunde, it's not wrong. But excess of peanuts are going to be trouble.
Unmute, Ali, unmute. Ali, unmute. Unmute. Ali, you can unmute and ask.
No, it is unmute.
Yes, now talk.
I say barley in what form can be taken?
Barley can be added to your idli batter, to your dosa batter.
Okay.
You can have barley upma, barley khichdi. You can add barley in the form of a soup.
She's my sister from Trivandrum. Okay, anybody else? Ranganathan, sir?
Thank you, doctor. So your program is so excellent. I appreciate for your concern and for this period of COVID. And you are organizing very well, and you are bringing knowledge in science and also this. And also this. I am very much happy, proud of you, doctor.
Thank you. The most important information is not to consume alcohol. very good.
I mean, dyslipidemia, what diet can we take, madam?
There are a couple of questions just come in, sir. If you can just check the chat box.
Aiza, how
Hello.
to take seeds like flax, either roasted or raw form?
You can take it, add it to the dosa batter, to the gravy, or consume directly and chew on it, sir. You can just take a teaspoon and chew on it. Or add it to your idli batter, dosa batter while preparing. You can add it to your poriyals or to your chapati dough in any form.
Dalma Nasri has asked, ma'am, please suggest the health drink for type 1 diabetic child.
You can choose on a low glycemic index supplement. If you want me to mention the name, you can use either Vivans Diabetic or Ensure Diabetes Care or Resource High Protein.
Dr. A. Hassan, what about stomach upsets? What diet to be taken?
Stomach upset is a long history by itself, sir. It all depends. You have to eat home cooked, sir, and choose a lot of curd and buttermilk, which will do wonders to you. If you're having diverticulosis, you're not taking enough of fiber. It all depends on what sort of stomach upset, but no non-vegetarian and no spicy food. Basically, bland diet, chemically, mechanically, and thermally non-irritating. Take soft food, take small quantity of food, plenty of curd, plenty of buttermilk, avoid processed foods. Our idli and parpu sadam will do wonders, sir.
Excellent. I think, are there any other questions? No? If there are no questions, then I would like to thank Professor Dr. R. Madhavan and Dr. Meenakshi Bajaj for the yes. You have something? Ali Kribrani. Can you unmute?
So for the fatty liver, what are the things that we need to take to reduce the fatty liver?
First of all, stop alcohol, good glycemic control, and weight loss. Zip your lip and move your lip, automatically the fatty liver will settle.
Physical activity is the one recommended worldwide. Reduction, 10% weight reduction is enough to bring down the triglyceride level in the hepatocytes.
Basically, zip your lip and move your hip.
Okay, very good. Ali Kribrani.
Kribarani. Yeah, what about the paneer? Paneer can be taken by the diabetic patients?
Yes, paneer can be taken because it is a source of good quality protein, but you cannot take it prepared from buffalo milk,
Hello.
or whole milk, because it will add on to your total cholesterol and triglycerides.
Okay.
But occasionally, if you take paneer, it's not good because you are allowed 7% of saturated fat from your total daily diet.
Okay.
So occasionally, you can take it from whole milk, but on routine basis, prefer to take it from, skimmed milk or home prepared paneer.
Okay.
But you cannot take paneer butter masala and say Meenakshi Bajaj said to have paneer.
Okay.
Dr. Ishwaran, you have something to ask? Dr. Ishwaran?
Hello.
Yes?
Yeah, this is Dr. Kayalvidi Balamurugan from Pondicherry. I don't have any questions, but I want to appreciate the whole team. It was an amazing session. I was so happy, and I'm very much thankful to the organizers and also Dr. Meenakshi. So many times we used to listen to her. Even then, whenever we listen, we are deriving energy. Not only the knowledge, attitude, and skills and other things we are developing or improving or disseminating the information. We are deriving energy. The whole session was superb. Thanks a lot to the organizers. Thank you.
Thank you, Valveri. Thank you.
Thank you, sir.
Thank you, ma'am.
Okay, I think I thank profusely Professor Dr. R. Madhavan as well as Dr. Meenakshi Bajaj, who in fact has given a voluminous and a very elaborative lecture on COVID-19 and diabetes, as well as COVID-19 and immuno-boosting the nutritious food that has to be taken. And Dr. Meenakshi has in fact promised that she'll be sending by mail to us, and we will forward to every one of you the real immuno-boosting diet which is being given for COVID-19, especially those patients who are admitted there for quarantine in Omandur Hospital, and also the concoction that has to be taken every day, that combination will also be sent to us, which has to be taken in either a glass of water or in a glass of milk, that pepper, turmeric, and all their proportions, which all will be sent to us, and we will forward it to you all. Thank you very much.
Thank you, doctor. Thank you, doctor.
Okay.
Thank you so much.
Nice program. Thank you, sir.
Thank you, doctor.
Oh,
Thank you, sir.
Thank you all
Thank you
very
so much,
much.
sir.
Thank you.
Thank you. See you, sir.
Thank you.
Meenakshi, bye.
Thank you, sir.
Thank you,
Bye,
doctor.
sir.
Thank you, doctor.
By the diet metrics, which is written by Dr. Meenakshi.
Thank you, sir.
Very useful for us.